The meeting is called to order. Please take your seat. And may I have your attention to make a very important announcement that has to do with a program of work of Committee B today. But before I do that, let me use this opportunity to thank you very much for the collaboration we have enjoyed from you so far, and we will encourage you to continue in that spirit. A meeting was conducted between the President and both Committee A, Committee B leadership, and it is to move an agenda item 15, which has to do with promote health, from Committee A to Committee B. So it is important to make this announcement for members to factor it into their plan, and a similar announcement will also be made at Committee A. Thank you. Ladies and gentlemen, we shall start our work this morning with a review and adoption of our second report. You may refer to document A79/38 draft, and I would like to give the opportunity to the rapporteur who will read out the draft report. You have the floor, Ms. Shalaka Cudjoe.
Good morning, everyone. 22 May 2026, draft A79/38, second report of Committee B, draft. Committee B held its third and fourth meeting on 21 May 2026, chaired by Dr. Kwabena Minta Akando, Ghana, and Mr. Bonanza Perwira Tahitu, Indonesia. It was decided to recommend to the 79th World Health Assembly the adoption of the attached 3 decisions and 3 resolutions relating to the following agenda items. 17. Health conditions in the occupied Palestinian territory, including East Jerusalem and in the occupied Syrian Golan. 17.2. Health conditions in the occupied Palestinian territory, including East Jerusalem, one resolution as amended. Power and performance. 18. Review of and update on matters considered by the Executive Board and the Program, Budget and Administration Committee of the Executive Board. Budget and finance matters. 18.3. Status of collection of assessed contributions, including member states in arrears in the payment of their contributions to an extent that would justify invoking Article 7 of the Constitution. One resolution as amended. Audit and oversight matters. 18.7. Report of the external auditor. One decision. 18.10. Proposed amendments to the process for the selection of the external auditor. One decision. Staffing matters. 18.15. Amendments to the staff regulations and staff rules. One resolution entitled Salaries of Staff in Upgraded Positions and of the Director General. 19. Appointment of representatives to the WHO Staff Pension Committee. One decision. Thank you.
Thank you, Ms. Cudjoe. Are there any comments or observations? I see none. May I then take it that the committee adopts its second report I see no objection, and it is so decided. This report will be submitted to the next meeting of the plenary. We will now resume discussion on agenda item 20, collaboration within the United Nations system and with other governmental, intergovernmental organizations, and sub-item 20.1, reform of the global health architecture and the UN80 initiative. We will continue with the established list of speakers from yesterday afternoon session as projected on the screen. So may I give the floor to Slovakia.
Thank you, Chair. Slovakia aligns itself with the cross-regional statement delivered by Cyprus. In the current challenging and rapidly evolving global environment, Slovakia supports the proposed reform of the global health architecture with central role of WHO in it. We agree that the present circumstances call for a more coordinated, agile, and impactful global health system capable of responding effectively to current and future health challenges. Slovakia advocates for a lean process while avoiding overly complex and resource-demanding structures. Although the financial situation within WHO may appear as stabilized, it is essential that the new mechanism does not create any additional financial burden for the organization and its member states. We also underline that global health environment involves a broad range of actors beyond member states and international organizations, which play an important role in it and should be therefore appropriately included to the discussions. Slovakia supports a transparent and consensus-based approach that strengthens coordination among all relevant actors. We hope that at the conclusion of the process, clear, actionable, and implementable recommendations will be available to support the achievement of the overarching objectives of the global health architecture reform. I thank you.
Dominican Republic, you have the floor.
Buenos días. República Dominicana.
Good morning. The Dominican Republic recognizes the strategic relevance of the process to reform the global health architecture and its relationship with UN80 in a global context which is marked by institutional fragmentation, financial restrictions, changes in disease burdens, and acceleration of artificial intelligence and digital technologies. We welcome the leadership of the member states in this process, and we support a global health architecture which is more coherent, inclusive, and focused on countries' real needs. From the national perspective, this is a discussion which is in line with our National Health Strategic Plan to 2030, which seeks to build the capacities of the public health ministry to lead the health system. The global health architecture, therefore, should strengthen national health authorities and avoid fragmented approaches or parallel structures which lead to duplication of work and additional administrative burdens. We are looking for a balanced model with effective representation between the global north and south, with more harmonized financial models which are aligned with national priorities and are sustainable. It's fundamental that the areas of work explicitly include the use of AI, the digital transformation, and data interoperability for medium-income countries. These are essential tools to strengthen epidemiological surveillance in real time, optimizing decisions, and building interoperable systems. Thank you.
Canada followed by Gambia.
Thank you, Chair. Canada supports WHO hosting joint, time-bound discussions to consider the various reform processes underway, including the UN80 initiative, and what these parallel reforms collectively mean for the global health ecosystem and its future trajectory. We welcome the emphasis on transparency and inclusive participation and consider the current joint task force configuration to be a positive step in this direction. In Canada's view, this process should generate clear and actionable recommendations grounded in evidence and analysis for the consideration of the relevant governing bodies. To this end, the Joint Task Force should, 1, strive to articulate a shared vision of a more coherent and effective global health architecture, 2, identify gaps and overlaps across the system, and 3, synthesize proposals emerging from related processes, including those linked to UN80. As many have said before, and particularly this week, global health is at an inflection point. Or to put it another way, there is an opportunity and collective responsibility before us to do things differently. Let's make sure that our discussions and decisions on global health reform, regardless of the process and regardless of the forum, deliver for those most in need, protect the major gains we have collectively achieved, reinforce country leadership, and propel us towards universal health coverage as the foundation of the resilient and equitable health systems we are all striving for. Je vous remercie. I thank you.
Gambia followed by Panama.
Chair, Excellencies, distinguished delegates. On agenda item 20, the Republic of the Gambia appreciates the good work the Secretariat is doing and thanks them for the report on the document A79/23. We welcome the continued efforts to strengthen collaboration across the United Nations system and with other intergovernmental organizations. Such collaboration is essential to addressing the complex and interconnected challenges facing our health systems, including pandemics, climate change, and the growing burden of non-communicable diseases. For the Gambia, effective multilateral collaboration has been instrumental in advancing national health priorities. Our partnerships with agencies such as UNICEF, the World Bank, and regional bodies have supported progress in health system strengthening, maternal and child health, and health financing reforms. However, we note that fragmentation of efforts and limited coordination at the country level continue to affect efficiency and impact. In this regard, the Gambia highlights 3 priorities. First, enhancing coordination and joint programming across the UN system at country level, aligned with national development frameworks and priorities. Second, promoting greater efficiency through reduced duplication and improved resource harmonization. Third, strengthening country ownership and leadership in coordinating external support to ensure sustainable and impactful outcomes. Chair, we also encourage continued efforts to leverage regional platforms and intergovernmental organizations to support collective action and shared learning. The Gambia remains committed to working with the United Nations system and partners to advance integrated, efficient, and country-led approaches to health and development. Thank you.
Panama followed by Colombia.
Gracias.
Thank you, Chair, and thank you for the reports. We welcome this initiative, which moving towards a more efficient GHA focused on countries' needs, strengthening national leadership, stakeholder coordination, and the alignment of finances with genuine needs. What's particularly relevant is that this process reaffirms the WHO as a global health leader in a context of financial restrictions and increasing institutional complexity. Chair, my country would like to state the following. The success of this reform is dependent upon effective and fair participation of all countries, particularly with those of low and medium income. We want to avoid increasing gaps. And it's important that we move towards a better harmonization of mandates and functions, reducing fragmentation, ensuring better coherence in decision-making and collective action. 3, there is a need to move towards more sustainable financing, which is aligned with national priorities. That's a key element for resilience. Fourth, it's essential to have greater clarity in terms of understanding the task team, including their methods of work, so that we can have transparency in this process. 5, it's important to assign appropriate resources without additional burdens on the existing budget. The reform of the global health architecture is not just a technical exercise. It's an opportunity, a historical one, to tap synergies between countries, improve equity, and ensure that healthcare systems effectively respond to current and future challenges. We reaffirm our commitment to participate actively in this process and contribute to building a more robust, effective, and inclusive global health system. Thank you.
Colombia, followed by Malaysia.
Gracias, señor presidente, por darme.
Thank you, Chair, for giving me the floor. As we said in the PBAC meeting, our delegation is concerned because the information provided by the Secretariat with regard to the Global Health Architecture reform is not sufficient. There's been a focus on methodology and organizational matters without clearly addressing substantive matters and the central issue of the reform. It can have a huge impact on the public nature of the WHO as a UN specialized agency. It has been through many stages of reform, many processes of reform in the past, under DG Brundtland beginning in 2000, and also Margaret Chang's reform at the beginning of her first term, and also the reform led by DG Tedros at the beginning of his mandate. 6 months from the end of the current mandate of the DG, there is a proposal for a new global health architecture reform. So we'd ask for greater clarity from the Secretariat. What is being reformed and why? As the delegation of Chile has already said, we would emphasize that any reform needs to protect the public, multilateral character of the organization as the UN Agency for Health. It's a reform that needs to be carried out without the interference of private commercial interests. Thank you.
Malaysia, followed by China.
Thank you, Chair. Malaysia reaffirms our steadfast support for the reform of the global health architecture and the United Nations 80 initiative. We welcome the proposed roadmap and emphasize that inclusivity must remain the cornerstone of this process, ensuring that the sovereign voices of all member states are heard and respected. We appreciate WHO's commitment to transparency, evidenced by the hybrid monthly information sessions. Malaysia further advocates for the robust use of written consultations. We view this as a vital mechanism to ensure that member states, particularly those navigating logistical or time zone challenges, can contribute consistently, equitably, and meaningfully. While we recognize the value of engaging diverse stakeholder constituencies and the expertise that they will bring to the table, we reiterate that this must remain a member state-led process at its core. Malaysia stands ready to support a transparent, inclusive transition that reinforces global solidarity and truly leaves no one behind. Thank you, Chair.
China, followed by Mozambique.
Mr. Chairperson, China supports multilateralism and the WHO's central coordinating role in the global health governance system. We believe that reform of the global health architecture must adhere to the principles of member states' leadership and decision-making. The relevant reform proposals should give due weight to the views of developing countries, focus on the core functions of different organizations, and be consistent with the UN80 reform principles so that we can avoid further fragmentation of global health functions. At present, the most prominent issue in global health development is the significant reduction in official aid. The relevant countries should honor their relevant commitments, and the reform measures should serve to meet the legitimate aspirations of developing countries, promote their equitable access to health products, and ensure their fair participation in global health governance. China supports increasing the frequency of collective consultations among all member states in Geneva to bridge differences, seek consensus, and ensure that future reform proposals for global health architecture can be acceptable to all parties. Such reform measures should be practical and feasible, thereby contributing to the global endeavor of building a community of health for all. Thank you, Chair.
Mozambique, followed by South Africa.
Thank you, Mr. Chair, for the floor. Mozambique aligned the statement delivered by Zimbabwe on behalf of the member states of WHO Africa region on the reform of the global health architecture. The health crisis associated with the increased severity and frequency of extreme weather events, demographic change, globalization, conflicts, among others, call for us for urgent reform in global health architecture. However, these reforms should be grounded in core principles of country ownership, multilateralism, and mutual consent. Africa carries the heaviest burden of disease, while remaining the less prepared and the most affected by the recent drop of official development assistance. For this reason, Mozambique defends that Africa should speak as a one voice to ensure that reforms can address country and regional demands and priorities. We also defend that WHO should remain a strong pillar for multilateralism in global health, with reinforced capacity and resources to deliver its mandate efficiently. In closing, I reiterate the commitment for Mozambique with a member state-led joint process with wide engagement and participation of all stakeholders. I thank you very much.
South Africa, followed by Pakistan.
Thank you, Chair. South Africa aligns with the statement delivered on behalf of the Africa region, as well as the Global Leaders Network countries, and welcome the report. We reiterated the centrality of WHO in the reform process and welcome the establishment of a joint interagency process coordinated by WHO Secretariat, bringing all stakeholders involved in global health and reporting to member states through governing structures of the World Health Assembly. We underscore and reiterate that the process should be member state-led. This said that we believe that member states should be fully involved in final decision-making process on the type of future global health architecture we envisage. Whilst we appreciate the principle of inclusivity in the task force, we submit that ultimately the ownership of the outcome emanating from the process can only rest with member states, which would ultimately ratify any formal decision. In conclusion, it is our firm view that standing on sovereign member state should not only be undermined, but rather be protected against undue influence. A future global health architecture and commensurate financing should ensure countries' ability to deliver universal health coverage while conferring health systems resilience against public health shocks, especially as we entrench equity on the pandemic agreement. This includes supporting member states towards strengthening their health system to prevent, prepare for, respond to health emergencies and of international concern and pandemics. I thank you.
This is a turn of Pakistan, followed by Indonesia.
Thank you, Chair. Pakistan commends the Secretariat and Dr. Bruce Alvord in particular for the inclusive engagement with member states throughout this process. We also appreciate France and other countries who worked constructively with developing countries in shaping this outcome. Pakistan has consistently maintained that reform of the global health architecture must be member state-led, inclusive and transparent. Reform must not translate into reduced ODA, weakened WHO country presence, or diminished support for developing countries. Lean, Chair, must not become synonymous with less. Genuine reform demands sustained and predictable financing, accelerated transfer of innovative technologies to build long-term self-sufficiency, and a process that keeps national health systems strengthening at its core. On the task force, the draft decision is unambiguous. Nomination discretion rests with the regions, and the co-chair arrangement ensures balance between developing and developed countries. The text means what it says. We caution against importing conditions that were neither negotiated nor agreed. The decision must be implemented as adopted in both letter and spirit. Geneva-based consultations, Chair, are the bedrock of this process. Bypassing missions, which are the accredited and authoritative voice of member states, would strike at the very inclusiveness this reform is meant to embody. Pakistan supports the draft decision. We would, however, welcome the opportunity at the end, perhaps, to propose some refinements to the text and look to the Secretariat for guidance on how best to bring these forward. I thank you very much.
Indonesia, followed by Nepal.
Chair, we thank the Secretariat for the proposal for a joint process. The imperative for a global health reform is clear. Too many actors perform the same works, ODA is declining, and countries pay the price through weaker results. It is natural that these actors should talk to each other. But talking is not enough. The reform must strengthen and consolidate WHO's normative, standard-setting, and system-wide convening role. And our expectations are threefold. First, it must build convergence across ongoing reform initiative. Second, it should deliver something concrete, mapping of existing initiative, system-wide analysis of overlaps, gaps, and comparative advantages, clear options for division of labor across the full range of global health actors. And third, it should set measurable country impact indicators and safeguards for equity and continuity of critical supports for developing countries. At the heart of this process lies one principle. It must always be member states-led. The delegations in Geneva hold the bird's-eye view of the whole architecture. There must be monthly consultation with member states in Geneva to track progress and to keep this process transparent and accountable. And the process must be feasible to all member states at every stage, and not only to those in the Joint Task Force. And these are our understanding of the draft decision recommended by PBEC 44 in document A79/31. We stand ready to engage constructively in the process with a view to an outcome that enjoys the broad consensus an issue of this magnitude deserve. And this is the one opportunity we have to transform the global health architecture. Let us do it right and let us do it together. Thank you.
Nepal has the floor, and that ends the list as read out yesterday, then will be followed by Mexico.
Mr. President, Nepal thanks the Secretariat for the proposal on this important agenda item. My delegation also wishes to express its appreciation for the opportunity provided during the PBAC last week to engage in informal discussions. These exchanges have helped clarify several important aspects of the proposed reform process. As we move forward, my delegation wishes to emphasize the following 3 points. First, the reform process must not compromise the support being provided to member states at the country level. The strength of the global health system ultimately rests upon the quality and consistency of implementation at national and regional levels. We trust the process will not be used to justify the funding cuts. Second, the effectiveness of global health initiatives depends fundamentally on coordination and alignment. Global health initiatives must not operate in silos or worse, work at cross-purpose. The reform process presents an opportunity to strengthen coherence, and ensure that initiatives work in synergy to support member states' health agenda. And finally, the process that will be initiated should ensure balanced representation of developing countries in the joint task force. Moreover, consultations for this member states-led process in Geneva should be inclusive with participation of low and middle-income countries. We appreciate the clarification that was made by the PBAC on this matter. Mr. President, Nepal is committed to supporting this important WHO-hosted reform process. We stand ready to engage constructively in the months ahead so that we arrive at an outcome that can be owned by all member states. Thank you, Mr. President.
Mexico, followed by Iran.
Muchas gracias. Thank you, Chair. And thank you to the Office for its report and the update on the new global health architecture and UN80. With the active participation of the WHO in various working groups under the principle of line 3. As we've said in PBAC, we believe that the intergovernmental approach and character of the WHO should be recognized and remembered in the taking of decisions and the following of any process. We need to also recognize the guidance offered by the membership. The role of UN80 with its impact on health is something that should continue to be considered by the relevant bodies of the WHO. It's important to analyze how to incorporate ARES or 686, which we approved in the UN in March, particularly with regard to operative paragraphs 31 and 32, in order to ensure a systematic approach to the creation and consideration of mandates. We value the fact that the process is seeking a more effective, result-oriented GHA, and we should seek to add value, avoid duplication, and not create new administrative burdens or parallel structures. We need to ensure this process is based on operational viability, efficiency, and valid criteria for countries, particularly those with lower institutional and financial capacity. Mexico supports a country-driven approach with the relevant decisions being used as a guidance inspired by the member states, driven by the member states, and applied accordingly. We believe that any approach should be transparent with a regional balance on the basis of consensus and respecting the decisions of the relevant management bodies. Thank you very much indeed.
Iran, followed by Armenia.
Thank you, Mr. Chair. The Islamic Republic of Iran wishes to thank the Director General for his report. While we acknowledge the need for a more coherent, effective, and equitable global health architecture with WHO at its central pillar, my delegation wishes to emphasize the following. First, the ongoing reform process of the global health architecture takes into consideration the different levels of development, national circumstances, and domestic health priorities of each member state. Similarly, regional context remains a crucial element in this process. A one-size-fits-all approach for all member states and all regions is neither practical nor just. The unique epidemiological, economic, social, and infrastructural realities of each country, particularly developing countries, must be reflected in all options and recommendations arising from this joint process. Second, before any proposal or recommendation is finalized, it must be shared with all member states in a timely manner, allowing sufficient opportunity for each member state to review, provide comments, and seek clarifications. The principle of national sovereignty and country ownership cannot be upheld if decisions are effectively made without the full and prior engagement of affected countries. Mr. Chairman, Iran supports a transparent, inclusive, and member state-driven process. We look forward to constructive engagement in the task force and related consultations, provided that the process remains truly collaborative and respectful of the diverse realities of all WHO member states. Thank you.
Armenia, followed by Jordan.
Thank you, Chair. Armenia supports efforts to build global health architecture that is better aligned with country and regional needs, avoids fragmentation and duplication, and strengthen core functions such as norms and standards, surveillance, technical cooperation, sustainable financing, accountability, and international cooperation. In this context, Armenia wishes to underline the importance of ensuring that treaty-based instruments and their governing bodies are reflected in the process. The WHO, FCTC, and the Protocol to Eliminate Illicit Trade in Tobacco Products are legally binding public health treaties and important pillars of global health governance. As the future host of COP12 and MOP5 in 2027, Armenia attaches particular importance to ensuring that FCTC system is appropriately included in the reform process and encourage in this regard structured engagement with the Convention Secretariat, with the Bureau of COP and MOP are appropriate stages of the process, at the appropriate stage of process. Armenia supports a reform process that strengthens coherence across WHO, the wider UN system, global health initiatives, regional organizations, and treaty bodies, while preserving the integrity and authority of the existing legal instruments. Thank you.
Jordan, you have the floor, followed by Saudi Arabia.
الرئيس الموقر أصحاب المعالي والسعادة المدير.
Chair, Your Excellencies, Director General, the Emiro states would like to thank the DG for the report and the Secretariat for the consultations which have been carried out as part of the process under the guidance of the organization with regard to the reform of Global Health Assembly and UN80. We welcome the clear approach which has been taken as part of this process, based on three objectives, namely the harmonization between the mandates, improvement of coordination, and improving decision-making at the regional and national level, as well as improving alignment with financing with regional, financial, and global needs and objectives. In order to continue moving forward, our region believes that efforts should see practical outcomes at the national level. The enhancement of work at the national level and ensure financing for sustainable development, particularly with those countries with limited resources. We also welcome the comments in the report relating to equity, solidarity, and national ownership, transparency, inclusivity, and utility. With regard to our region, where a number of countries find themselves in situations which can be described as precarious, where there are humanitarian emergencies, these principles are essential if we're going to achieve effective and equitable results. And we also welcome the inclusion of financial considerations as one of the key elements here. Sustainable finance needs to be predictable and harmonious for national health systems and universal health coverage as we seek to build preparedness and the capacity to respond, particularly in those countries where resources are limited. We also welcome the integration of essential health functions in this process, taking as a model the approach for national healthcare systems and the national healthcare models. We also believe that there needs to be a more effective response to humanitarian emergencies. So reforms need to enhance support to countries subject to huge pressures on huge financial pressures. Furthermore, emphasis should be put on the fact that this is a process which should be guided by member states. It should be inclusive, transparent, and effective, because effective participation will require balanced representation and access to info in due time. The speaker has been interrupted.
Saudi Arabia, you have the floor, followed by Lebanon.
شكرا معالي الرئيس. تعرب المملكة.
Thank you very much. Kingdom of Saudi Arabia would like to express the high esteem it holds the report on global health architecture in. We believe that emphasis should be placed on all reform efforts and contributing to greater effectiveness of the global health system while preserving the role that the World Health Organization plays as a body which has leadership in the area of health. We would place the emphasis on the fact that any reform needs to be steered by member states based on inclusivity, inclusion, and equity, with avoidance of duplication and fragmentation, which would have a detrimental impact on multilateralism and health. We need to take into account the needs of developing countries and the regions of the world in order to ensure that we can boost national ownership and develop a participative approach, which is essential for this process. The WHO should continue to participate actively in consultations that are taking place in the context of UN80. Member states need to be kept abreast of the developments of the various possibilities and the impact on the organization and its mandate. Thank you.
Lebanon, followed by Norway.
Mr. Chair, distinguished delegates, Lebanon aligns itself with the statement delivered by Jordan on behalf of the Eastern Mediterranean region and welcomes the timely DG report. Lebanon supports the decision at a moment when the global health landscape continues to evolve under the pressures of shrinking development assistance, complex emergencies, and heightened geopolitical tensions. As we are recovering from years of compounded crises, the proposed reforms to the global health architecture and the UN80 initiative carry both profound implications and important opportunities. Fragmentation across global health actors has long strained our national system, creating duplication and sometimes misalignment with country priorities. Lebanon therefore stresses that global reform must place country leadership as its core, ensuring that national priorities guide collective action. We also highlight the importance of inclusiveness with specialized organizations, academia, civil society, and humanitarian partners working alongside WHO to deliver coherent support across humanitarian, development, and peace domains. The UN80 initiative's focus on mandate clarity, structural coherence, and agile country-level operations is highly appreciated. For us, a reformed global health architecture must be equitable, resilient, and speaks to the realities of preparedness for any threats, response to emergencies, and recovery from our lagging crises, together with addressing the growing burden of non-communicable diseases. We strongly support WHO's proposal for a joint, inclusive process to define a common global health architecture framework, and we stand ready to contribute to the process. Any new operating model must reinforce, not dilute, WHO's normative leadership and technical authority, particularly where national capacities remain fragile. Lebanon remains committed to shaping a global health architecture that delivers real impact, strengthens resilience, and ensures that WHO remains at the center of coordination while countries lead based on their priorities and benefit from the inclusiveness of specialized organizations. I thank you.
Norway, you have the floor, followed by Pakistan.
Thank you. Norway supports the proposal for a joint process to support reform of the global health architecture. We hope for this exercise to provide bold recommendations on best ways to avoid gaps and fragmentation, strengthen coherence, and provide coordinated support on country level. We need a strong global health ecosystem that will support national priorities and the transition to domestic financing, as well as promote global public goods for health. Norway's objective is that WHO should emerge with a strengthened and central role in a reformed global health architecture. We reiterate the importance of building on existing analyses, reform initiatives, and the UN80. The declining trends in financing for global health also call for increased engagement with multilateral development banks and international financial institutions. It's not only a question of alignment, but how we can do better with less. Strong political leadership is essential to build consensus on shared objectives and translate them into concrete measures across regions and institutions. Further follow-up will necessarily depend on the respective mandates, governance structures, and timelines of different organizations, boards, and initiatives. Finally, inclusiveness is central to the process, and all stakeholders should have meaningful opportunities to contribute, including civil society, affected communities, youth, and other stakeholders. We urge all involved parties to engage in this constructive and collaborative approach, mindful of own interests and roles. Thank you.
Haiti, you have the floor.
Merci, Monsieur.
Thank you, Chair. Haiti wishes to begin by thanking the Director General for this report, and we support its ambition to recraft the global health architecture to make it more coherent, more efficient, and more equitable. For Haiti, there are some fundamental principles that must underpin reform. WHO is a member-driven organization. The reality of life for people living in our countries has to be improved, and national health situations have to be improved. That is what has to lie at the heart of any transformation. The current architecture has allowed us to make significant progress, but it remains marked by fragmentation, overlap, and sometimes excessive expectations in terms of what is decided at headquarters level and the reality of the situation on the ground. We need to give particular thought to countries in fragile contexts with limited resources. And in that context, we have a number of priorities. Firstly, we need country-driven leadership with better aligned funding to country needs and funding that is more predictable and more flexible when it comes to building up healthcare systems, especially PHC. Secondly, we need to strengthen the regional level of what we do, because at regional level, people are better placed to understand the operational realities countries face and to bring to bear effective regional solidarity. Thirdly, we need to guarantee more inclusive governance, especially for small states, fragile countries, and areas that have been underfunded for many years. We need to ensure that their needs are genuinely taken into account. And the fourth priority, we need a more coherent architecture, better coordination, less duplication, and easier access to key tools and instruments, especially innovative technology today. We know, Chair, that our nations have borders, but those borders cannot define our humanity. And what we need to do is to take an approach that truly puts the needs of people at its heart. Thank you.
Thank you very much. As I have no more delegations on my list, Pakistan, do you want to take the floor, or is a mistake?
Thank you, Chair. It's not a mistake.
Okay, you have the floor.
We would definitely like to take the floor. And thank you very much for giving us the floor again. Chair, as I mentioned in my previous intervention, we would like to take this opportunity to thank colleagues from the Secretariat, colleagues from member states, who have engaged very constructively on how this document is shaped. We are very happy with this document. However, we have a minor comment in document A79/31 under provisional agenda item 21, in particular in 4B. And I would explain the rationale for why we are suggesting. We have been saying, repeatedly that member states need to be at the heart of this process. This process must be led and driven by member states with inclusive, transparent consultations and regular consultations with member states. I think most of the elements we have mentioned, the draft decision adequately captures that. And as I said, we are completely fine with that. We just have some minor tweaks, in particular in para 4B, where it mentions that the monthly global consultations and information sessions, as appropriate. What we have been requesting and suggesting is that these should be consultations. I don't think consultations and information sessions are the same. I think information session could be an information session where some information is presented without necessarily being a consultation. So we would like, to remove information sessions as appropriate from the text. We would suggest that this minor tweak should be taken into account. And there's another thing. I think the draft decision, as it stands currently before us, it suggests that once the final report is prepared, it can go to GHIs before it's presented to the World Health Assembly. What we would like here, and we would request your indulgence, Chair, is that we would like to have member state consultations each time a report is presented. So the current draft decision envisages 2 reports.
Thank you very much, Pakistan. I can see there are no more delegations on my list. So I would like to invite representatives of the United Nations and international organizations to give their remarks. And so, United Nations Population Fund, you have the floor.
Thank you, Chair. Excellencies, Director General, the reform of the global health architecture provides a decisive opportunity to move toward agile, integrated, resilient, equitable and rights-based health systems. Ensuring SRHR and gender equality must be foundational pillars, not optional add-ons of global health governance. In our pursuit of a more effective multilateral system, we must safeguard the unique mandates and institutional strengths that are indispensable to global health. UNFPA is a proud contributor to strengthening national health systems through supporting SRH services, including in conflict and crisis settings. Moreover, we work to address the social and economic barriers holding millions of women and girls and young people back. The success for a renewed global health architecture rests in its ability to mobilise the whole of government and society in addressing health needs and its social determinants throughout the life course, to promote health for all, everywhere. Thank you.
Gavi, the Vaccine Alliance, you have the floor.
Thank you, Chair. Gavi strongly supports the WHO-hosted process to advance the reform of the global health architecture. In a rapidly evolving landscape, closer collaboration will be essential to building a more coherent, country-led, effective, and resilient ecosystem that is fit for today's challenges. Gavi welcomes the opportunity to contribute to the proposed task force and commits to engaging in a constructive and collaborative manner, dedicating the necessary time and expertise in support of this process in close collaboration with Member States, WHO, and partners. We remain committed to supporting a transparent and action-oriented process that delivers practical recommendations for reform. Engaging the governance bodies of the various actors impacted by this process will be critical to clarifying comparative advantages, sharpening the division of labor, and strengthening collaboration across the future health architecture. Thank you.
United Nations Children's Fund, please, you have the floor.
Thank you, Chair. Excellencies, Director General. Children have the right to health, and the current and the next generation deserve a global health architecture that is fit for purpose, one that can continue to deliver results for children in a changing and increasingly complex world. For this reason, UNICEF welcomes the proposed WHO-hosted joint process to reform the global health architecture. UNICEF will work to ensure that these discussions align with the UN80 process and the broader system-wide reform efforts. With more than 50% of under-5 mortality now occurring in humanitarian and fragile settings, it is essential that global health reform is aligned with humanitarian reform. Public health emergency preparedness and response must also place children at the center. Serious outbreaks have demonstrated how quickly children face disproportionate risk through disrupted immunization, malnutrition, and reduced access to essential services. UNICEF will engage constructively to ensure maternal, newborn and child health remains central to these efforts and that strong, resilient primary health systems are at the core of delivering an equitable and sustainable world for all. Thank you.
Global Fund, you have the floor.
Thank you, Chair. The Global Fund welcomes the proposed WHO-hosted joint process on the global health architecture reform. We are fully committed to working with WHO partners and stakeholders to help reshape the ecosystem, to better respond to country priorities and achieve greater collective impact. The proposed process should place sustainable financing of national health systems and equitable access to health communities and services at its core. Global health partners should align efforts to support countries on their pathways towards self-reliance, while acknowledging that countries are not in the same state of readiness. Engaging humanitarian partners in the discussion will be critical. Civil society organizations and communities also play a vital role in achieving efficient and equitable health services, and their engagement in this process should be adequately resourced. The Global Fund stands ready to contribute to the proposed task force and will be guided by our board on how to further adapt in complementarity with partners to maximize impact for the countries and communities we were created to serve. I thank you.
UNAIDS, you have the floor.
Thank you, Chair. AIDS has never been only a medical health challenge. It's always been shaped and too often driven by inequality. And the HIV response has shown that when we tackle stigma and discrimination, when we address exclusion, and when we listen to communities and share power, we get results that are stronger and more sustainable. That is part of what UNAIDS and the Global AIDS HIV response can offer as global health is reformed, a model in which communities and civil society are not just consulted, but are part of decision-making, a model that is more inclusive, accountable, more grounded in people's realities, and stronger because power is shared. And when we should expect this new architecture to be renewed, countries leading strong responses, investing more in their own resources, building sustainable systems, and working across sectors. We know what works, Chair. Now we need to have the courage to build on it. Thank you.
Several non-state actors in official relations with WHO have requested the floor on this sub-item, that I shall first give the floor to the representatives of Drugs for Neglected Disease Initiative.
The NDI welcomes discussions on reform and emphasizes that product development and equitable access must be treated as core functions that are addressed coherently across all work streams. Market forces alone will not deliver the new health tools needed to meet public health priorities. Reform discussions must address how innovation systems are designed, governed and financed to serve public health and equity objectives. This includes ensuring sustainable financing for R&D, embedding access conditions in public investments, strengthening regional research and manufacturing capacity, and supporting technology transfer and data sharing. We also stress the importance of recognizing and strengthening proven public interest R&D models, including product development partnerships that have already delivered innovation where market incentives are weak or absent, while supporting long-term partnerships and research capacity in partner countries. Thank you.
International Association for Suicide Prevention, you have the floor.
The International Association for Suicide Prevention welcomes the discussion on the future of global health architecture, yet we note that mental health and suicide prevention have remained largely absent from these reform conversations, despite over 1 billion people living with mental health conditions worldwide. Architecture designed without this reality risks deepening the very inequities reform seeks to address. We urge Member States to ensure people with lived experience of suicide and mental health conditions, alongside civil society, the workforce, young people and academics, are meaningfully embedded in the consultation process at every stage. We further call for a person-centered approach that recognizes the comorbidities between physical and mental health and places mental health at the center of architecture built for current and future global health need. Thank you.
International Federation of Medical Students Associations. International Federation of Pharmaceutical Manufacturers and Associations.
AFPIME believes a stronger global health architecture should foster innovation, strengthen health systems so innovations reach people, and forge partnerships to advance health globally. For the joint process to succeed, 3 safeguards are essential. First, it should clarify mandates, comparative advantages, and decision pathways across institutions, including how recommendations affecting organizations beyond WHO will be considered by their own governing bodies. Second, it should ensure balanced participation, with the private sector included alongside civil society in core structures, including the Joint Task Force and any time-limited working groups where relevant. Third, product innovation and access should remain within WHO's constitutional and member state mandated functions. It should not drift into IP, licensing, pricing, procurement, manufacturing, or supply decisions. AFPIME stands ready to contribute. Thank you.
Knowledge Ecology International.
The UN 80 initiative is a system-wide reform effort to make the United Nations more agile, efficient, and coherent. An important and neglected reform concerns the harmful impact of economic and technology trade sanctions. The intersection of international law, trade sanctions, and public health is governed by a complex mix of formal multilateral frameworks, human rights obligations, and state practices. While there is a broad consensus that medicine, medical equipment, and humanitarian goods should not be used as weapons of economic warfare, the legal, economic, and practical applications of these exceptions reveal a significant gap between international norms and reality. This should be discussed at the next WHA 80. Thank you, Chair.
Medical Women's International Association, you have the floor.
Thank you.
Thank you, Chair. The Medical Women's International Association, representing 12,000 female physicians across 70 countries, welcomes the proposed WHO-led reform of the global health architecture as an important opportunity to strengthen multilateral cooperation, equity, and accountability. At a time of geopolitical instability and constrained health financing, WHO's leadership role as the coordinating global health authority is more essential than ever. We recommend that the proposed reform includes greater engagement of parliamentarians as direct representatives of the constituencies and as policymakers responsible for approving health policies and budgets. Finally, as a non-state actor in official relations with WHO, we stand ready to contribute to this historic process under the leadership of the World Health Organization. Thank you.
Medicus Mundi International, Network Health for All.
Thank you. This statement is supported by the People's Health Movement. Honorable Director General and Member States, this is a moment of possibility. Through WHO reform and the UN 80 initiative, we can build a stronger, more effective WHO to the fragmented global health landscape. This requires predictable and sufficient financing through the SS contributions, reinforcing WHO's normative authority, and defending WHO's role as a central coordinating authority in global health. It also demands democratic governments with meaningful participation of countries and public interest civil society organizations. At the same time, we urge caution. Expanding decision-making roles to private actors and global health partnerships risks diluting accountability and undermining WHO's public mandate. Reimagining, WHO must strengthen, not weaken its independence. With ambition and solidarity, you can view WHO as a trusted, people-centered institution delivering health for all. Thank you very much.
Rotary International.
Thank you, Chair. Strengthening the global health architecture
is essential to ensuring that our collective systems are coordinated, resilient, and capable of delivering equitable outcomes. Reform must prioritise sovereignty, reduce fragmentation, and reinforce core public health capacities. The Global Polio Eradication Initiative exemplifies effective architecture through its multi-partner model, uniting national leadership, shared accountability, and coordinated action at scale. Its surveillance, laboratory, and rapid response systems now underpin broader health security and resilience, while its equity-driven approach reaches the most vulnerable. As reforms advance, leveraging GPEI's capacities will preserve gains, strengthen country systems, and demonstrate that a coherent, inclusive architecture can deliver lasting results for all. Thank you, Chair.
Station Health Action International. Welcome, Trust.
Good morning, Honourable Chair, esteemed delegates. Welcome considers the joint process to support reform to the global health architecture to be timely and crucial, but there needs to be a significant increase in ambition. It is critical this process delivers much-needed substantive reforms that redistribute power and embed new ways of working. It must consider opportunities to streamline the landscape through merging and consolidating organisations. As currently proposed, this process seems to lack this mandate. This process must also be genuinely inclusive. It should foster ownership and active engagement among member states from all regions and ensure civil society is included as a member of the task force. Finally, the process must ensure dialogue leads to a concrete, actionable proposals. Without these, the opportunity to build a better system will be missed. Thank you, Chair.
Women Deliver.
Thank you, Chair. On behalf of Arrow, Women Deliver, and Kaleidoscope Collective, we welcome the Director General's report on the proposed joint process. However, to overcome systemic fragmentation and the power imbalances, the new architecture must firmly anchor equity at its core. True global health equity and resilience are impossible without achieving UHC that fully integrates comprehensive access to health, including sexual and reproductive health and rights. We urge the Joint Task Force to align financing streams to support nationally owned long-term social protection systems that can withstand economic and climate shocks to enable increased public investment in health required to achieve UHC, guaranteeing safe, timely, and uninterrupted access to comprehensive health information supplies and services. Finally, we urge member states to ensure that civil society, especially from the Global South, are meaningful co-designers throughout all phases of this reform to truly leave no one behind. I thank you.
World Federation of Public Health Associations.
The World Federation of Public Health Associations welcomes the inclusive approach to reform the global health architecture and strengthen coherence with the UN80 initiative. At a time of global instability in health financing, young health professionals are disproportionately affected by job losses, reduced opportunities, and excluded from decision-making. Yet young people represent nearly half of the world's population and will live with these long-term consequences of the reforms. This is a pivotal and historic moment to turn the tide. We call on member states to ensure meaningful youth representation, including on the Joint Task Force, and to embed intergenerational equity as a guiding principle. The World Federation of Public Health Associations and its Young Professional Working Group stand ready to support this process. Thank you.
International Pharmaceutical Students Federation. Thank you. Since they are not here, let's move on. In order to wind up on the agenda item under discussion, I will give the next opportunity to Pakistan to wind up in the next 30 seconds so that we move on. Pakistan.
Thank you very much, Chair. Thank you for your kind indulgence. I would just want to add that currently the process, the way it's structured in the draft decision, it envisages that the final report will be shared directly with the GHIs. We would like to have member states consultation before the interim and the final report is shared with GHIs. Thank you.
Good. I think Secretariat have taken note of your request. As there are no more speakers on my list, I would like to give the floor to the Secretariat to respond to any questions raised. And at this point, I may invite Dr. Mohamed Yakub Janabi, Regional Director for the African region.
Chair, thank you. On behalf of WHO regions, we welcome this proposal as a timely and necessary turnpoint. Across our regions, member states are clear. They want a global health architecture that is more coherent, more equitable, and genuinely country-led. One that reflects today's realities and is prepared for future challenges. We fully support a reform process that is inclusive, transparent, grounded in national priorities. Excellencies, at the heart of this reform is a simple principle. Decisions should be taken as close as possible to the people we serve. WHO regional platforms are essential, translating global norms into country actions, strengthening cross-border preparedness, delivering regional public goods, and ensuring that the voices of low and middle-income countries shape global decisions. But structure alone is not enough. We must reduce fragmentation, strengthen coordination, and improve accountability across all actors to deliver results at scale. At the same time, WHO must continue to evolve, operating as one integrated organization, eliminating duplication and reinforcing its core technical and normative clues. Chair, this is a rare opportunity to reshape the global health architecture. Let us act with unity, urgency to build a system that delivers better health for every country and every person. I thank you.
Dr. Razia Pensy, you have the floor. Chef de Cabinet.
Thank you, Chair. Good morning, everyone. I would like to thank the Member States for their comments in support of the joint process for the Global Health Architecture reform to be convened by WHO, and more importantly, with the active engagement and guidance also to the run-up to the session here at the WHA. We would also like to thank our many collaborators in shaping this joint process, the GHIs, UN partners, World Bank, and the civil society organizations, and thank them for their trust in WHO jointly leading this process. There was a specific question from Colombia that what is new in this reform, as WHO has been reforming, especially under the current Director General. Indeed, WHO has done a lot on transformation under the current Director General, and we have heard of these transformation and reforms through the WHA sessions this time. What we are discussing right now is actually a first global health architecture reform. And I would just like to reassure that there are multiple safeguards in the process to protect both the role as well as the mandate of WHO. The current global health architecture has achieved great successes, but as the discussions previously and today have indicated, it has not always kept pace with today's changing world. For reform of the global health architecture, in support of countries, it should be led by member states, working together to find shared solutions to shared challenges. WHO will approach this mandate with humility and with an inclusive spirit. You have asked for a joint process with key partners, one that is transparent and fully respectful of member state leadership. The Secretariat will leverage WHO's unique convening role to make sure that the membership has strong avenues to remain actively engaged. That will include regular briefings at all levels, including global hybrid consultations that coordinated from Geneva. You also have asked for a joint process that is time-bound and efficient without adding additional administrative and financial burden in a fiscally constrained environment. To that effect, we will build on existing reform efforts and maintain strong linkages to all related processes, including the UN80 reforms. You have set out clear principles for this work, including national sovereignty, regional cooperation, equity, solidarity, and accountability. These will indeed guide the process throughout. We have heard you and your comments, and the way we will implement the agreed process will be reflected in the WHA summary records. For WHO, any recommended changes will be reviewed by and decided by you, our member states. Thank you for the trust you have placed in the organization to take forward this very important process. I thank you. Back to you, Chair.
Dr. Tedros, Director General, you have the floor.
Thank you, Chair. I would like to start by thanking our member states and also our partners. Thank you so much for your advice, guidance, and support. This global health architecture, there are just a few things I would like to say without repeating what colleagues had said. Is to say that it should be seen, the global health architecture reform should be seen in relation to what we're doing internally in WHO. As you know, we have been doing restructuring the past 16 months, and we're trying to focus the organization on its core mandate and make it leaner, more effective, and more efficient. So in that process, we are identifying areas that can be done by other partners. So the success of the internal restructuring actually helps the GHA also succeed. What I would like to assure you is, from WHO side, we will do our best to honestly identify our core mandate, and then what can be done by other organizations based on the mandate of other organizations or their comparative advantage, we will make sure that it's done by others. It's that kind of genuine and honest move that can help the GHA succeed. By doing that, we will avoid duplications, and we will align, and at the end of the day, align to help countries succeed. And all we do in the GHA should actually be bottom-up, and we need to understand the needs of the countries we support and shape up based on that. So there is the internal process, the internal change that's happening, and there is also the GHA, the Global Health Architecture Reform that we're trying to do now. Thank you for approving showing support to the GHA process. I think the two are interlinked. That's what I'm trying to say. And the other issue I'd like to include is, I think some of you have raised it, the support we're getting in terms of the assessed contribution, the two that you have already done in 2023 and May 2025, has helped to minimize the impact of the funding cuts during the internal restructuring process, which I said. But not only that, it has helped us to stabilize. And WHO now stabilized and moving on. And the added value is with the additional installments we're expecting in 2027, 2029, and 2031, the proportion of the assessed contribution vis-à-vis the total budget will be significant. The estimate is now it could reach between 50 to 60%. So for the future, especially with all the installments done, the organization will be more resilient and can prevent shocks like this, and also makes the organization more independent. I think some of you have commented that what you need is an organization which is independent and serves or puts people at the center and serves humanity without fear nor favor. So both the internal and the GHA should help us to position WHO to be exactly that. But what's giving us confidence is the finance reform we started with you that's already being implemented, that will help in making the organization more resilient and independent. So that's what I would like to add. And the GHA should not be seen in isolation. And then final, you asked for transparency, you asked for inclusive process, you asked for genuine division of labor, and so on. We have taken note of all your recommendations, and we will make sure that we abide by your advice and guidance. But finally, thanks again for your support to our member states and partners. The rule of this game is together, and we will make sure that we share, we do our share. Thank you, and Chair, back to you.
Thank you, DJ. I'll give the floor to Medicines for Malaria Venture.
I don't think it's possible. Thank you, Chair, for this opportunity to speak. Medicines for Malaria Venture welcomes the debate on the global health architecture. New tools can transform the fight against disease, but scientific innovation must go hand in hand with ecosystem innovation. And a reform of the architecture can help address system-wide challenges that persist, such as how to sustain research funding, how to strengthen ownership of regulatory approval and policy adoption in disease-affected regions, how to accelerate country introduction and supply management of new tools. So the Member States and WHO have today the opportunity to engage with the power of science in the reform and with proven models, including product development partnerships, which have shown the ability to deliver innovation when market incentives are limited, and to co-develop research and manufacturing capacity across the world, and especially in disease-affected regions. Thank you.
Thank you very much for your contributions, and I dare say that all your contributions will be reflected in the records. Thank you. Is the committee prepared to note the report contained in document A79/23? There's an objection. Pakistan, you have the floor.
Thank you, Chair. No, Chair, there is no objection. We would just like to seek some clarification. I think the Chef de Cabinet referred to it. We made a very specific comment with regards to 4B, and we would just like some reassurance from Chef de Cabinet that those comments have been captured and how the Secretariat intends to deal with them. I thank you.
Yeah, Chef de Cabinet, please, may you clarify?
So, as I had mentioned, all the comments will go into the WHO summary records, and the implementation of those as we move forward in the process, that would be taken in. So what you have commented on the decision in terms of it should be consultations, Geneva-based consultations, and that there should be member state consultations before anything is sent to the other boards. We have taken note, and that would be acted upon as we move the process forward, if that satisfies your query. Thank you so much.
In the absence of any further intervention, the report is noted. Is the committee prepared to note the report contained in document A79/24? I see no objection. The report is noted. Is the committee ready to approve the draft decisions as contained in paragraph 4 of the document A79/31? I see no objection. The decision is approved. That concludes our consideration of these agenda items. Distinguished delegates, it is my information that consultations are still ongoing among member states on agenda item 20.2, and that a little bit more time is requested to complete these consultations to come to an agreement. So at this point, I suspend for 20 minutes. The meeting is accordingly suspended for 20 minutes. Thank you. just for the information of the committee, we'll have additional 30 minutes break. Just for the information of the committee, we'll have additional 30 minutes break. So we'll resume after the next 30 minutes. Thank you. The meeting is called to order. Please, let's take our seats. Distinguished delegates, we shall now open discussion on sub-item 20.2, communications of the United Nations Secretary General as depository of the Constitution of the World Health Organization. The relevant document is A79/5 Add 4, as well as draft resolution in EB 15812 contained in document EB 158/2026/Rec/1. Under this agenda item, we shall also consider document A79/B/Conf/2 and A79/B/Conf/3, which contain amendments to a draft resolution. Dear delegates, I understand the proponents of the document would like to take the floor on procedural matters. I will now give the floor to Norway, followed by Paraguay.
Thank you very much, Mr. Chair, and we appreciate that there has been informal consultations on this matter. And thanks to the flexibility shown by all involved, these consultations have been fruitful, so that we are now in a position to support the outcome of these consultations, which is presented for the consideration of this committee as a proposed text that has just been circulated. We understand, Mr. Chair, that this text is also supported by the proponents of Conference Paper 3, which is why we accordingly withdraw Conference Paper 2 in support of the proposed text which has just been circulated as the /4 conference document. I thank you very much, and we encourage the support of this compromise by the wider membership. I thank you.
Paraguay, you have the floor.
Thank you very much. On behalf of my delegation, our thanks go to those who participated in formal consultations on this matter, and we are in a position to support the outcome of those consultations. So we withdraw Conf 3 and support the proposed text, which has now been circulated. My thanks in Guarani go to everybody, and thank you very much.
I will now give the floor to the Secretary to read out the proposal that has been circulated.
Thank you, Mr. Chair. Let me just first bring your attention to the technical error in the document, so please disregard the words withdrawal of the Argentine Republic from the World Health Organization. This will be deleted and the proposal will be recirculated. This will not be reflected in the proposal. So the proposal is the follows. Amendments to the draft resolution contained in decision EB 158/12/2026. Outcome of informal discussions. The 79th World Health Assembly, taking note of the recommendation contained in decision EB 158/12 and the report by the Director General, having noted the communication from the Minister of Foreign Affairs, International Trade and Worship of the Argentine Republic, dated 25 February 2025, and received by the United Nations Secretary General 17 March 2025, notifying the letter that the Argentine Republic withdraws from the World Health Organization and that the withdrawal would be effective 1 year after the receipt of the letter. Resolves that while the World Health Organization will always welcome the Argentine Republic's full cooperation in the work of the organization, it is not considered that any further action at this stage is desirable. Thank you, Mr. Chair.
I will now pause for 10 minutes for delegates to reflect on the proposal before you. Paraguay, you have the floor.
Muchas gracias. Thank you, Chair. We would prefer that the document in its corrected version could be circulated so that we could better consider it. We have been told about the change, but it does constitute an additional concern. So if the Secretariat could circulate the updated version, then we'd be able to make our decision on a good basis. Thank you.
May I invite the Secretariat to read a new title?
Thank you, Mr. Chair. The correct title will be Communications of the United Nations Secretary-General as Depository of the Constitution of the World Health Organization. If I may reassure you, Mr. Chair, that we are reprinting the document. It will. Thank you.
I trust this clarifies the concerns of Paraguay. Thank you. Paraguay, you have the floor.
Thank you to the Secretariat for reading out what they did, but my request remains. It does cause us concern. So we would like to have the correct circulated text so that all delegations can then be duly informed as they make their decision. So our thanks go to the Secretariat for having read the document again. We would like to have the paper version with the changes that the Secretariat did read out. Thank you.
Thank you. The new title is being printed, and we can assure you that it will take some time, but then it will be circulated in the room in the shortest possible time. Thank you. But in the meantime, may I call on the Secretariat to project the full text on the screen as the printing is ongoing. I hope we now have in our possessions the correct titles of the document being circulated. And it is important to remind you that we have the correct title and the content still remains same. So we'll give few minutes and then we move on whilst you are considering it. Let us now consider the proposal you have before you. And may I take it that the committee is ready to approve the proposed test, which is what you have before you. Paraguay, you have the floor.
Señor Presidente.
President, we need just a couple more minutes because some delegations are still discussing. Thank you.
Let's give ourselves in the next 5 minutes. Distinguished delegates, I want to suspend this sitting for us to resume after lunch for additional consideration of the issues before us. So we'll resume exactly 2 o'clock in the afternoon. Thank you. The meeting is called to order. Distinguished delegates, it is my information that more time is needed to arrive at an agreement on agenda item 20.2. And therefore, I want us to move on to agenda item 15. Thank you for understanding. We will now take up the grouping of the following agenda items under Promote Health. Sub-item 15.1, Strengthening Rehabilitation in Health Systems. Sub-item 15.3, The Health of Indigenous Peoples. Sub-item 15.4, Maternal, Infant, and Young Child Nutrition. The relevant document is A79/5. Under sub-item 15.3, we are also invited to consider the draft decision recommended by the Executive Board in decision EB 15810, contained in document EB 158/2026/Rec/1. The floor is open. Angola, you have the floor.
Thank you, Chair. The African regions welcomes the progress achieved in the development of global rehabilitation indicators and recognize the importance of collecting robust data to guide realistic targets adapted to different national contexts. Strengthening rehabilitation service in the integrated and decentralized manner within health system is a growing priority in Africa. In line of the increases in non-communicable disease, road traffic accidents, disability, mental health condition, and the health consequence of conflict, we support the development of global indicators and targets aligned with countries' capacity, as well as the strengthening of national systems for data collection, analysis, and use for decision-making and integration into primary health care. The goal remains to promote the functional independence, social inclusion, and economic participation of the individuals concerned. The regions take notes of the constraints arising from the current WHO prioritization process and understanding the need for additional time to produce a final evidence-based support. With regards to the health of indigenous people, we recognize the persistent inequalities in access to health service, nutrition, water, and social protection, exacerbated by poverty, social inclusion, and climate change. The African region supports the Global Action Plan for the Health of Indigenous People, including the generation of evidence, access to health service, community participation, the integration of traditional medicine into health system, and free, prior, and informed consent. On maternal, infant, and young child nutrition, we recognize the process achieved by challenges such as anemia, low birth weight, and right childhood overweight persists. In the context of global finance constraints, countries are strengthening domestic resource mobilization, the integration of intervention into primary health care, and multi-sector coordination. We also express the concern regarding the inappropriate digital marketing of breast milk substitute and call for strengthening national regulatory and monitoring frameworks in line with the international code. The African region expresses its full support for the resolution under consideration, which reflects intercontinental and essential priority for health system and for achieve the SDG. I thank you.
El Salvador, you have the floor.
Thank you, Mr. Chair. Ladies and gentlemen, the Committee on Victim Assistance on the Anti-Personal Mine Ban Convention, comprised of Austria, El Salvador, Mozambique, and Sri Lanka, welcomes the continued attention of the WHA to strengthening rehabilitation in health systems. The states party to the Anti-Personal Mine Ban Convention are committed to ensure that mine and other explosive ordnance victims can access timely, quality, and affordable rehabilitation. The Sim Rehab Anchor Action Plan 2025-2030, adopted by the state parties, call for the integrated and human rights-based approaches. A week ago, El Salvador, with assistance from the EU Council, hosted by a regional event on victim assistance, where access to sustainable rehabilitation was extensively discussed, participants from across the Americas called for the increased efforts to strengthen rehabilitation systems, echoing the global momentum created by WHA 76.6 and Rehabilitation 2030 initiative. Allow me to highlight a couple of points we would like to share. We stress on the importance of the integrating mine victims' needs into national rehabilitation policies, strategies, and service delivery. Survivors of mine and other explosives ordnance often require lifelong multidisciplinary rehabilitation. Their needs should be included into national and universal health coverage package. We draw attention to the growing rehabilitation needs in mine-affected countries. Many states face rising demand due to the ongoing casualty leading to the new impairments, aging survivors, and limited local capacity, particularly in rural and remote areas. This challenge mirrored the global trend highlighted in the WHO Director General's report and reinforced the urgency of expand quality rehabilitation, strengthening referral pathway, and investing in the rehabilitation workforce. We support the full implementation of Resolution WHA 76.6 and welcome the development of global rehabilitation indicators and encourage continued collaboration. Finally, we underline the importance of accessibility and affordable assistive technologies and the full inclusion and participation of persons with disabilities, including survivors, in relevant effort. I conclude indicating the committee appreciation for the collaboration between WHO, including the World Rehabilitation Alliance and the Mine Action Community. We reaffirm our support for WHO efforts to strengthen rehabilitation assistive technology and disability inclusion. Thank you, Chair.
Ecuador, followed by Jamaica.
Señor Presidente.
Thank you, President. Distinguished delegates. Ecuador expresses its thanks for the reports on strengthening rehabilitation in health systems, the health of indigenous peoples, and maternal, infant, and young child nutrition. Our country recognizes that advancing towards more equitable health systems requires integrated, person-centered approaches with intercultural, community-based, and rights-based approaches. On the health of indigenous peoples, Ecuador reiterates its commitment to bridging the historic gaps in access to healthcare for those communities. Through our integrated family, community, and intercultural health model, we strengthen the incorporation of ancestral medicine, intercultural dialogue, and community participation as key elements to guarantee appropriate care, respectful of the cultural diversity of our peoples and nationalities. We also recognize that maternal, infant, and young child nutrition is vital for human development and breaking cycles of poverty and inequality. Ecuador has a strategy on growing without infant malnutrition, strengthening prenatal care, child health checks, immunization, and promotion of breastfeeding. We also support strengthening human milk banks, breastfeeding rooms, community spaces that benefit thousands of mothers and children in situation in vulnerability. We see this as a priority for strengthening rehabilitation towards universal health care, promoting quality of lives, inclusion, reducing inequalities, especially persons with disabilities, chronic conditions, post-traumatic syndrome, and conditions linked to aging. Our country also is working on progressive integration of rehab services into primary health care. We think it's vital to strengthen international cooperation financing, the exchange of experiences among member states. We think we need to see more inclusive, resilient, and intercultural health systems where nobody is left behind. Thank you.
Jamaica, followed by Belgium.
Chair, Jamaica commends the Director General on the consolidated report. Jamaica has made progress in aspects of the implementation plan on maternal, infant, and young child nutrition and is working towards meeting the global nutrition and operational targets for 2030. Jamaica is on track to meet the global target for wasting, stunting, and childhood overweight. But despite the significant progress made with breastfeeding, Jamaica is not on track to meet the 2030 target. In 2025, Jamaica conducted a media assessment of the International Code of Marketing of Breast Milk Substitutes, finding widespread and deliberate marketing that exposed caregivers to misleading messages. The country will strengthen policies to align with WHO resolutions and protect breastfeeding as a public health priority. Jamaica will continue implementing measures to protect, support, and promote breastfeeding, including enforcing the National Infant and Young Child Feeding Policy and strengthening the health system to address key issues, including increasing the number of nutrition professionals in primary care and increasing access to care in various settings, strengthening the nutrition surveillance system, strengthening the baby-friendly hospital initiative, development and implementation of guidelines for workplace support for breastfeeding, implementation of a communication strategy for infant and young child feeding, and strengthening community support for breastfeeding through infant and young child feeding networks. Thank you.
Belgium, followed by Sri Lanka.
Thank you, Chair. The stagnation and in some areas the reversal of progress toward the global nutrition targets is alarming. The prevalence of child obesity is rising and the consumption of sweetened beverages is presently high, which are major sources of concern for our country. In Belgium, half of the population is now living with overweight or obesity. Obesity is driven by a wide range of determinants, including commercial determinants, and is deeply shaped by socio-economic inequities. A recent OECD report on the health and economic benefits of tackling non-communicable diseases has made clear how steep increases in obesity are undermining the hard-gained progress we have made on reducing NCD risk factors. Belgium firmly believes that nutrition policies must be rooted in independent, evidence-based public health guidance. We should not rely on voluntary self-regulation by industry. WHO's guidance and leadership are key in this regard to promote healthy diets, breastfeeding, and health-supportive environments. In addition, we must improve health literacies and ensure transparent and science-based information of consumers. Finally, we wish to highlight the importance of a One Health approach regarding food systems, including nutrition and food safety. Human, animal, and planetary health are intertwined, and healthy and sustainable diets generate co-benefits. Thank you.
Sri Lanka, followed by China.
Thank you, Chair. Sri Lanka acknowledges the reports under the agenda items 15.4 on maternal, infant and child nutrition, 15.3 on the health of indigenous peoples, and 15.1 on strengthening rehabilitation in health systems. Sri Lanka remains committed to strengthening equitable and people-centered health services across the life course. On maternal and child nutrition, Sri Lanka has integrated evidence-based nutrition interventions into the National Maternal and Child Health Program, sustained investment in the preventive health system, including the public health midwives network and the baby-friendly hospital initiative, has enabled Sri Lanka to maintain high breastfeeding rates, with exclusive breastfeeding currently at 82%. Sri Lanka has also introduced restrictions on the advertising and promotion of foods to children up to 12 years of age. However, food insecurity continues to affect the vulnerable communities, particularly in estate sector and urban under-settlement areas, aggravated by the economic crisis and climate-induced shocks. We are also concerned about the growing and largely unregulated digital marketing on breast milk substitutes and unhealthy foods targeting children. Sri Lanka therefore calls for a stronger health regulatory frameworks and sustainable financing to support nutrition programs and essential nutrition commodities. Sri Lanka also recognizes the importance of culturally sensitive healthcare services for indigenous people. Meaningful engagement with the indigenous leaders and communities is essential to ensure that health interventions reflect their needs, traditions, and beliefs. Our National Health and Traditional Medicine Policy 2024-2034 reflects this commitment. On rehabilitation, Sri Lanka has prioritized strengthening rehabilitation services across all levels of healthcare in line with Resolution 76.6. Rehabilitation has been incorporated into the national health policies, workforce training, and health sector planning. Efforts are ongoing to improve health resources, data systems, infrastructure, community-based rehabilitation, home care services, and telemedicine. Finally, Sri Lanka reaffirms its commitment to building resilient,
China, followed by Morocco.
Thank you, Chair, delegates. China thanks the DG for the consolidated report and appreciates WHO's efforts in strengthening rehabilitation in health systems and advancing the improvement of maternal, infant, and young child nutrition. China has the following two comments. First, on strengthening rehab in health systems, China agrees with the proposal in the DG's report to integrate such services into public health and emergency preparedness systems. We suggest that WHO encourage countries to step up such rehabilitation services and increase the supply of primary rehabilitation medical services. Focus should be given to key groups such as children and older people, and strengthening capacity building for specialized rehabilitation services such as childhood autism and cerebral palsy to ensure rehabilitation services are equitable and accessible. We're ready to share our experience and share our practices with other countries. Second, on maternal, infant, and young child nutrition, China notes that global nutrition improvement is still challenged by uneven progress. We suggest that WHO maintain focus on childhood anemia, stunting, and obesity, improve nutrition policy exchange platforms, and promote practical technical tools. Focus should be given to nutrition improvement in remote, rural, and fragile areas, and regulation of digital marketing for breast milk substitute should be strengthened. It should also address the practical difficulties of breastfeeding for working women and promote the construction of a fertility-friendly society. We're ready to share our practical experience, such as nutrition packages for rural children. We stand ready to work with all parties to strengthen exchange and cooperation and promote the building of a global community of health for all. Thank you, Chair.
Morocco, followed by Philippines.
الرئيس الموقر أصحاب المعالي والسعادة المدير العام يعيش.
Thank you. Chair, ladies and gentlemen, in the EMRO region, we have 180 million people suffering from illnesses that should really see them benefiting from rehabilitation. And yet we have a scarcity of services. Rehabilitation isn't widespread enough, and in spite of that, countries in the region have made significant efforts and undertaken a considerable number of reforms, and we need capacity building, training for people responsible for rehabilitation, and guaranteeing equitable access to services at all levels, particularly for groups in vulnerable situations. The region reiterates its commitment to the health of indigenous peoples, recognizing the structural barriers that they face in getting access to healthcare services, particularly those in fragile or emergency situations. We thank WHO for having advanced this program in accordance with WHA 7716 and having carried out the relevant inclusive consultations in support of the Global Action Plan. We welcome this participatory process, which included collaboration with member states, indigenous peoples, UN partners, civil society actors, and universities. We welcome the regional consultation that took place in April 2026, bringing together 22 different countries and territories, and we sincerely hope that WHO continues to provide its technical support and operational support in this area to implement the Global Action Plan in accordance with national priorities. Chair, the region continues to face a high burden of malnutrition. In 2024, 24.3 million and 5.9 million children under the age of 5 suffered from stunting or wasting, and 4.2 million from overweight. 3 countries were certified for the elimination of trans fats, and 8 others adopted policies based on good practices to combat the use of trans fats produced industrially. And we welcome the WHO's role in promoting better nutrition and high-impact nutritional services, in particular supporting fragile communities and conflict-affected areas, and strengthening nutrition surveillance and supporting food systems to support healthy eating and overcoming conflicts of interest. Thank you.
Philippines, followed by Iran.
Thank you, Chair. The Philippines notes the report on strengthening rehabilitation in health systems and underscores its importance in advancing equitable and people-centered care. Rehabilitation is increasingly vital in our context, given the rising burden of non-communicable diseases, which contribute significantly to disability and long-term functional limitations. Addressing these outcomes remains a priority under our national 8-point priority agenda. We continue to face shortages in allied health workforce. In response, the Philippines is expanding service delivery through urgent care and ambulatory service centers and through community-based health teams that strengthen access to integrated primary care, including rehabilitation. We support the integration of rehabilitation across all levels of care and into public health and emergency preparedness. And we emphasize the need for feasible, context-appropriate indicators through a phased approach. On Agenda 15.3, the Philippines welcomes the decision to defer the Global Plan of Action for the Health of Indigenous Peoples to allow broader and more meaningful consultations. Nationally, we advanced this agenda through a rights-based framework anchored on existing laws, the Indigenous Peoples' Rights Act and the Universal Healthcare Act. We prioritize Indigenous leadership in planning and monitoring, strengthening primary health care in underserved areas, expanding financial protection, and institutionalizing cultural competency in health services. On maternal, infant, and young child nutrition, the Philippines reaffirms its commitment to national and global nutrition targets. We highlight the first 1,000 Days Act, expanded benefit packages, and strengthened domestic financing.
Iran followed by India.
Mr. Chair, in Iran, rehabilitation has been integrated into the health system through the National Medicine Rehabilitation Program in 2021. More than 60 rehabilitation centers have been established, with priority given to undeserved area alongside investment in equipment, workforce development, and insurance coverage. We recognize ongoing challenge in measuring rehabilitation coverage and functional outcomes and support the development of flexible approaches and practical monitoring tools. Iran stands ready to collaborate in pilot initiatives, technical cooperation, training, and regional capacity building. The Islamic Republic of Iran expressed concern over the reduction in international nutrition assistance and its serious consequence for women and children. Iran has implemented important initiatives, including the establishment of human milk banks, integration of nutrition counseling into the PHC system, taxation of unhealthy products, regulation of school canteens, national training programs, and monitoring of nutrition indicators through electronic health records and national surveys. In light of ongoing humanitarian crisis and population displacement, we emphasize on cost-effective interventions, including limiting digital marketing of breast milk, substitute, improving food fortification program, and ensuring facilitate access to a specific nutrition formula for vulnerable infants. Thank you.
India followed by Russian Federation.
Thank you, Chair. The integration of rehabilitation into public health systems is indispensable for achieving universal health coverage and strengthening resilient health systems. Rehabilitation services must be embedded across all levels of care: primary, secondary, tertiary, and incorporated into emergency preparedness and response frameworks. It is equally important to ensure that rehabilitation is reflected in national health policies with due emphasis on social participation, equity, and gender equality. Persistent barriers linked to geography, income, gender, and social vulnerability must be addressed to guarantee equitable access for all. Chair, India believes that indigenous peoples have an equal right to the enjoyment of the highest attainable standard of physical and mental health. Their meaningful participation in health-related decision-making through their representatives must be ensured. Furthermore, promoting intellectual and holistic approaches, along with recognizing indigenous knowledge systems and traditional medicine, is vital for advancing universal health coverage. Chair, under the National Health Mission, India has adopted a life cycle approach through the reproductive, maternal, newborn, child, adolescent health and nutrition strategy, ensuring multiple contact opportunities with beneficiaries. Initiatives such as the Mother's Absolute Affection Program promote breastfeeding, focusing on the first 1,000 days, while nutrition rehabilitation centers provide care for children, and acute malnutrition. In addition, community-based outreach programs are being implemented to build an enabling environment for infant and young child feeding practices. I thank you.
Russian Federation, followed by Canada.
Distinguished Chair, colleagues, we share the view that rehabilitation is a fundamental part of comprehensive health care, which must be accessible to all who need it. The Russian Federation consistently is increasing the number of patients receiving rehabilitative care at the level of primary care and beyond. We're developing and implementing a regional rehabilitation program, and we have equipment, and we're building our staff base. We have projects on a active life, and rehabilitation has reached over 1,000 people. Within the state fund, technical resources for rehabilitation are provided to those who need it, including children who need it and orphans. We also have a strategy on indigenous peoples. We work with providing medical care to those in remote regions. This includes telemedicine and air ambulance services. With respect to children and maternal nutrition, I'd like to note that we are developing comprehensive work in this respect. Within our family project, we are providing services to support breastfeeding, preventing disease, and deficiencies in children and mothers. Thank you.
Canada, followed by Japan.
Thank you, Chair. On item 15.3, Canada reaffirms its strong support for the Global Plan of Action for the Health of Indigenous Peoples, which we view as fundamentally Indigenous-led, recognizing Indigenous peoples as rights holders and leaders in defining priorities and approaches. We are committed to working with Indigenous partners, WHO, and member states to continue to strengthen the plan and support its implementation in ways that are respectful, inclusive, and responsive to diverse national and Indigenous contexts. Canada is supportive of WHO's proposal to put the plan in motion by integrating it into the GPW through technical assistance to countries, coordination, governance, and accountability mechanisms, and the development of normative guidance and capacity building tools. We emphasize that the plan's success will depend on whether it meaningfully supports Indigenous peoples' own priorities, governance, knowledge systems, and visions for health and wellness in alignment with existing human rights, equity, and gender equality commitments. On item 15.4, Canada welcomes WHO's work in advancing maternal, infant, and young child nutrition. We emphasize the need for policy environments that enable healthy diets across the life course, beginning in infancy with exclusive breastfeeding. Breastfeeding provides optimal nutrition, immunological protection, and promotes emotional nurturing of infants. Canada also emphasizes the need to address evolving food environments, including the impact of digital marketing and advertisement on infant and young child feeding practices. Strengthening guidance and regulatory approaches in this area remains important. Finally, Canada recognizes the importance of healthy school food environments to improve diet quality, prevent all forms of malnutrition, and help address the early rise of childhood obesity. Culturally appropriate, evidence-informed approaches can support inclusive and equitable policies responsive to women, infants, and young children. Thank you, Chair.
Japan has the floor, followed by Burkina Faso.
Thank you, Chair. Japan reiterates that rehabilitation services are an integral part of UHC. We welcome integrating rehabilitation into public health, emergency response, and health policy, as well as strengthening the capacity of the health workforce. We also underscore the importance of equitable access to rehabilitation services at all levels of care. In this regard, we call for effective and efficient support to help countries achieve UHC targets. Japan is concerned about stalled progress towards several global nutrition targets. We have been advancing nutrition policies that combine three key elements: food, human resources, and evidence. Registered dietitians and nutritionists are deployed in public health centers under national legislation and play a central role in supporting population health. They contribute to improving nutrition across the life course. Based on this experience, Japan believes that it is important to promote nutrition improvement through the development of nutritionists and other relevant professionals, so that each country can independently advance nutrition policies, including maternal, infant, and young child nutrition. In recent years, an increasing number of countries have shown interest in Japan's school nutrition program, including school meals, as well as food and nutrition education. Through bilateral cooperation, Japan International Cooperation Agency, JICA, provides support through technical cooperation projects and training programs in Japan. Japan will continue to support efforts to improve nutrition in countries and to achieve the global nutrition targets, drawing on its experience. I thank you.
Burkina Faso, followed by Slovenia.
Thank you, Chair. The delegation of Burkina Faso supports the statement delivered by Angola on behalf of the African region. My delegation commends the Director General on his consolidated report. We welcome this important discussion in these times of uncertainty, where those who pay the highest price are the most vulnerable, such as women, infants, and young children. In spite of that difficult, challenging international context, Burkina Faso has made considerable progress in maternal, infant, and young child nutrition. To illustrate that, I point out that between 2019 and 2025, stunting in children under the age of 5 fell from 25.4% to 17%. The rate of exclusive breastfeeding rose from 59% to 63.5%. Overweight in children under the age of 5 years fell from 1.3 to 0.9%. Wasting fell from 8.1% to 5.7%. Burkina Faso has also adopted several policies and strategies, including the multi-sectoral nutrition policy 2020-2029. It's established a national information platform for nutrition and integrated nutrition into the package of health training at community level. We reiterate our commitment to strengthen community-based high-impact actions, implementing WHO recommendations and strengthening maternal and infant nutrition and improving multi-sectoral nutrition governance. We encourage WHO to strengthen its support for member states in order to achieve the nutrition targets by 2030. And we wish to finish by taking note of the report and inviting the Assembly to adopt it. Thank you.
Slovenia, followed by Bhutan.
Thank you, Chair. Distinguished delegates, Slovenia supports the WHO action in breastfeeding promotion and support. Ministry of Health developed good cooperation in this area with the National Board for Breastfeeding Promotion at the Slovenian UNICEF as well as National Public Health Institute. This is also an important issue in the new National Nutrition and Physical Activity Strategy that is in the process of adoption. More coordinated and sustained action of all the stakeholders is needed, especially because breastfeeding is an important factor in obesity control. Because of this, there should be sufficient funding available for national coordination support and the promotion, including the use of baby-friendly initiative healthcare standards. This is also in line with the new WHO, UNICEF, and CAH strategy, high quality care area. I thank you, Chair.
Bhutan, followed by Ireland. Ireland, followed by Saudi Arabia.
Chair, Ireland reaffirms its strong alignment with the SDG commitment to end all forms of malnutrition, to improve maternal, infant, and young child nutrition, and to ensure that every child has the best possible start to life. Millions of women and children are still affected by various forms of malnutrition, while the current context of escalating crises and reduced levels of ODA threaten decades of progress. 5 million children under the age of 5 die every year. There are no words to capture the scale of this tragedy. And it is unacceptable that something as basic as access to the right food is a contributing, if not the primary, cause of death of these children. Some 20 million underweight children born each year and face lifelong challenges as a result. 1/3 of pregnant women are anemic and are unable to access the nutrients needed to ensure their infants can survive and fully thrive. Early intervention is crucial. We know that the first 1,000 days are critical and that investing in maternal, infant, and young child health is profoundly important and yields real results for health and well-being and for equitable economic growth and development. We welcome and commend the WHO's leadership and measures to advance nutrition, including science and evidence-based guidance on healthy diets, strengthen nutrition data, surveillance and monitoring, and the generation and scaling of evidence-based care and treatment. Ireland is deeply committed to working on nutrition domestically and through our international cooperation. In line with last year's resolution to extend the comprehensive implementation plan on maternal, infant and young child nutrition in 2030, we have pledged to spend €250 million annually with partners, including the WHO, to accelerate action necessary to end malnutrition and improve health outcomes globally. We know that nutrition is fundamental to health and well-being, and we also know the solution lies beyond the health sector. I conclude by noting Ireland's continued appreciation of the WHO leadership for its effective work to define, advocate and deliver policy and practice to move nutrition forward globally and in particular for countries and communities in crisis. Thank you.
Saudi Arabia, followed by United Kingdom.
Chair, the Kingdom of Saudi Arabia welcomes the efforts deployed by the organization with regards to strengthening rehabilitation and health systems. Rehabilitation is a main pillar of universal health coverage and participates in improving the quality of life, as well as community participation and economic development. Saudi Arabia stresses the importance of including rehabilitation services at all levels of healthcare, including primary healthcare, emergency care, and in the context of humanitarian crises. This care should be provided equally to all population without any distinction. We also stress the need of measurement indicators and a clear action plan in order to collect data and determine our targets in order to be able to provide full coverage for these rehabilitation services on the basis of evidence. We also commend the importance of building the capacity of the health workforce and expanding capacity building programs in order to provide these services equally, particularly for the most vulnerable communities in remote areas. With regards to maternal, infant, and young child nutrition, Kingdom of Saudi Arabia appreciates the report prepared by the Director General and stresses the need for accelerating the work in order to implement our nutrition targets. These must be included in our national plans. We also need to put in place plans to encourage breastfeeding while stressing the need to organize the promotion of breast milk alternatives in order to protect mothers and children. Thank you.
United Kingdom, followed by Senegal.
Thank you, Chair. The UK welcomes the consolidated report by the Director General with updates on the EB 158 discussion paper. Given that most countries are off track to meeting the global nutrition targets, we reiterate the importance of expanding coverage of essential nutrition interventions for vulnerable populations through the health system, within the Universal Health Coverage Agenda and focusing on strengthening primary healthcare. In this regard, we reaffirm the need for WHO to continue supporting member states to address the persistent underfunding in primary healthcare and to invest in robust and resilient health systems. We welcome the launch of the UNICEF WHO implementation guidance on wasting on the 20th of May. The United Kingdom is proud to have supported the development of the WHO guideline, and we are committed to turning evidence into action. We also note the strong evidence on the links between TB and nutrition. with a significant positive impact that addressing undernutrition in high-burden contexts would have on TB outcomes and TB incidence. We look forward to seeing the WHO post-2030 tuberculosis strategy for submission to the WHO in 2028. Ultimately, progress on nutrition outcomes will only be possible through scaling up nutrition actions through primary healthcare, integrated care, and through food systems that increase access to affordable and acceptable healthy diets. In this regard, we welcome the launch of the 2026 Global Nutrition Report during Rome Nutrition Week next week, which focuses on how health and food systems are being impacted by shocks and the need for stronger integration across both. Thank you.
Senegal, followed by Bahamas.
Je vous remercie.
Thank you, Chair. And Senegal is making a statement on 15.1. We align ourselves with the statement delivered by Angola on behalf of the 47 members of the African group. Senegal welcomes WHO's leadership in promoting rehabilitation as a key element of universal health coverage, and we reiterate our commitment to integrate prevention, rehabilitation, and assistive technologies throughout our healthcare system, according to a human rights, equity, and life course-based approach. Preventing avoidable health conditions is a priority in our strategy for transforming our health care system. We have some priorities that we are working on and bringing into line with WHO recommendations with the support of partners. The Boki Nasi project, to leave nobody behind, will contribute to strengthening national capacities and improving access to assistive technologies. In the short term, our priorities include setting up a centre of excellence for rehabilitation, drawing up a national rehabilitation strategy, and drawing up a list for priority assistive technologies and offering equitable and accessible services throughout our country. However, we face a number of challenges, including the high cost of equipment, dependence on imports of components and supplies, and capacity building needs. Senegal takes note of the report and calls for accelerated international cooperation for technology transfer. Thank you very much for your attention.
Bahamas, followed by Central African Republic.
Chair, the Bahamas commends WHO's continued commitment to strengthening rehabilitation in health systems. Our high burden of NCDs makes it essential across the life course, yet unmet needs remain significant. Our 2022-2023 assessment using the WHO STAR tool identified major gaps. In response, the Bahamas launched its first National Rehabilitation and Assistive Technology Strategic Plan 2025 to 2030, aligned with the WHO Rehabilitation 2030 initiative. We call for sustained WHO technical support for small island developing states, including stronger integration of rehabilitation into UHC financing and NCD strategies. Chair, the Bahamas also thanks the Director General for the report on maternal, infant, and young child nutrition with its sobering findings. Malnutrition in the Bahamas reflects a double burden, requiring integrated action on nutrition and NCD prevention. We are advancing reforms to the 2026 Promotion, Advancement, and Protection of Breastfeeding Regulations and Healthier Food Environment policies. However, challenges remain, including gaps in nutrition data, limited breastfeeding support systems, and increased digital marketing of unhealthy foods to children. The Bahamas urges WHO to strengthen its role in identifying new financing opportunities, convening developing partners, and supporting investment cases for maternal and child nutrition, NCD prevention, and digital marketing regulation. Finally, we remain committed to advancing this agenda and working with the Secretariat and Member States to ensure that every child has the best start in life. I thank you.
Central African Republic, followed by United Arab Emirates.
Merci, Monsieur le Président.
Thank you, Chair.
The Central African Republic wishes to congratulate the DG for this report on maternal and child nutrition. We also commend all efforts to put in place the comprehensive implementation plan for nutrition. The situation remains worrying, especially in African areas affected by insecurity, the Sudan crisis, which has also resulted in population displacement, as well as the problems in the DRC today. Given all of that, significant reform has been undertaken in Africa, and certainly in our country. We have emphasized that acute malnutrition is something that we have to tackle in accordance with the latest WHO recommendations, and we've started to do that. Within our national programs, we have included a particular section on early warning of signs of acute malnutrition. And in our 2026-2030 national plan, we've made it clear that nutrition policies will be included in our national PHC framework and our national health policies. We attach particular importance to breastfeeding. That being so, we have a national code for the marketing of breast milk substitutes, and this is something that is before our Parliament at present, and they are adopting a revised version. We are very much against digital advertising for breast milk substitutes that we see happening in an unregulated way today, and this is something that is of serious concern to fragile countries. We call for more international support to help us in this area and to help us build our national capacity to deal with early years malnutrition in particular, to ensure that everyone has essential nutrients, and to also ensure that we can enhance surveillance of marketing for breast milk substitutes in African countries. We are actively committed to fighting malnutrition so that every mother and every child can enjoy better health and a more dignified life. Thank you.
United Arab Emirates, followed by Republic of Korea.
Mr. Chair, distinguished delegates, the UAE aligns with the statement of the Eastern Mediterranean Regional Group and reaffirms its commitment to advancing maternal, infant, and young child nutrition as a foundation for healthy families and sustainable development. The UAE recognizes that the first 1,000 days of life are critical to lifelong health and well-being. Our national efforts include strengthened maternal and child health services, high-quality antenatal and postnatal care, breastfeeding support, food fortification, and programs targeting early childhood development and micronutrient deficiency prevention. At the same time, the UAE acknowledges evolving challenges, including childhood overweight and obesity, unhealthy dietary patterns, and digital marketing of unhealthy food directed at children, all requiring coordinated, forward-looking responses. In this regard, the UAE calls for action across 5 priorities: strengthening maternal nutrition through integrated lifelong services, protecting and promoting breastfeeding through baby-friendly facilities and work policies, fostering optimal complementary feeding through engagement with families, schools, and the private sector, strengthening regulatory frameworks to shield children from unhealthy food marketing, including on digital platforms, and investing in data system and research to track nutrition trends and underpin evidence-based policymaking. The UAE fully supports the adoption of this resolution and stands ready to share experiences and cooperate with member states and the Secretary to achieve global nutrition targets. Thank you.
Republic of Korea, followed by France.
Thank you, Chair. Regarding the item 15.1, the Republic of Korea supports the Secretariat's effort to integrate rehabilitation into essential health services. To strengthen the rehabilitation delivery system from the acute phase to community, the Republic of Korea is expanding health insurance coverage for rehabilitation treatments. We are also running a pilot project to designate and operate rehabilitation hospitals to ensure high-quality services. Furthermore, the National Rehabilitation Center for the Republic of Korea, acting as a WHO collaborating center, has been making dedicated efforts in the Western Pacific region. We strive to integrate rehabilitation into health systems and strengthen the capacity of policymakers and health workers. Turning to item 15.1, the Republic of Korea supports the Secretariat's works to achieve the 2030 global nutrition targets. We express our concern over the stagnation in indicators for overweight and anemia. For vulnerable pregnant women and infants under 72 months, we operate a program providing nutritional assessments, monthly counseling, and supplementary food. In addition, the ROK is working to establish a scientific basis for the nutritional management of infants and mothers. This includes revising dietary reference intakes for each stage of the life cycle. Meanwhile, we note the increasing cross-promotion of breast milk substitutes in digital environments. Therefore, we believe international cooperation is crucial for AI-based continuous online monitoring and cross-border data sharing. The Republic of Korea will continue to work closely with WHO in the fields of rehabilitation and nutrition. Thank you.
France, followed by Brazil.
Merci. Thank you, Chair. Chair, a third of the global population is affected by all forms of malnutrition, and this has significant repercussions on food systems, also on health and educational systems. As you have recalled, nutrition is a vital prerequisite for the achievement of 11 of the 17 SDGs. While progress has been made, the WHO report is absolutely clear. None of the 6 targets that were set globally is likely to be achieved by 2030, and there are worrisome trends when it comes to overweight and stunting. These are signals that require a strengthened collective response. France fully supports the comprehensive implementation plan on maternal, infant and young child health. We call for the pace of implementation to be stepped up, especially in fragile contexts. The first 100 days of life, from conception to the age of 2 years old, are vital and have to remain our collective focus. This implies promoting integrated health policies, protecting breastfeeding, regulating digital advertising for breast milk substitutes, and building national capacity when it comes to early prevention of malnutrition and appropriate training for health personnel. France is very much involved in food at school being provided, especially through the relevant global coalition. In March 2025, France hosted the Nutrition Summit for Growth. This mobilized $30.5 billion and resulted in more than 600 commitments. France calls upon all stakeholders to ensure rigorous implementation. Lastly, malnutrition cannot just be regarded as an emergency. We need to tackle the root causes. That requires better integration of nutrition in health, agricultural and environmental policies. Thank you.
Brazil, followed by Malaysia.
Mr. Chair, Brazil recognizes rehabilitation as an essential component of universal health coverage and resilient health systems. Beyond recovery, rehabilitation promotes autonomy, social participation, dignity, and quality of life. In Brazil, we have expanded rehabilitation services within primary health care and specialized care networks, while strengthening community-based approaches and assistive technologies. We emphasize that rehabilitation must be integrated throughout the continuum of care and accessible to all populations. We emphasize particularly those living in vulnerable territories and underserved areas. The Viva Mais Brazil strategy mobilizes citizens around the world around prevention, physical activity, and nutrition. Brazil reaffirms commitment to health of indigenous peoples, recognizing indigenous health that cannot be dissociated from territory, culture, spirituality, food systems, and environmental protection. While we regret the delays in the consideration of the Global Action Plan for Health of Indigenous Peoples, we recognize that broader resource constraints affecting the World Health Organization. Brazil has strengthened indigenous health governance, prioritizing intercultural approaches, social participation, and the expansion of access to primary health care in remote territories. We remain committed to an inclusive consultation process towards a robust global action plan in 2027. Finally, Brazil expresses its concern regarding the growing impact of marketing of ultra-processed foods, particularly in digital environments, on dietary habits of children and teenagers. In this regard, Brazil underscores the importance of strengthening regulatory measures aimed at protecting public health. Thank you, Mr. Chair.
Malaysia, followed by Panama.
Thank you, Chair. Malaysia notes the report on strengthening rehabilitation in health systems and the draft global plan of action for the health of indigenous people. Malaysia's national strategy is anchored in systems integration, embedding high-impact, low-cost interventions across the continuum of care to achieve global maternal, infant and young child feeding targets. By leveraging existing infrastructure and digital health tools, we ensure that every clinical contact point delivers essential infant and young child feeding counseling. This is further reinforced by the Healthy Eating Responsibility for Women initiative, which integrates minimum dietary diversity for women as a key proxy indicator of micronutrient adequacy. Malaysia also prioritizes minimum dietary diversity for infants and young children aged 6 to 23 months, a key indicator of diet quality and nutritional adequacy. These efforts are underpinned by strategic governance through our newly revised National Nutrition Policy, aligning the first 1,000 days agenda with the SDGs. However, we remain deeply concerned by the cross-border challenges of digital marketing for breast milk substitutes. Malaysia welcomes the WHO's support in strengthening international guidance on digital enforcement. Locally, we are currently planning the development of the Virtual Violation Detector, an AI-assisted platform designed to monitor and enforce the code of ethics within online environments. Through public-private partnerships and local innovation, Malaysia remains committed to ensuring the sustainability and resilience of our nutritional landscape. Thank you, Chair.
Panama followed by Gambia.
Gracias, señor presidente.
Thank you, Chair. Thank you also for the report. We commend the report on the rehabilitation of health systems, the health of indigenous peoples and mother-child nutrition. We recognise that healthcare system rehabilitation is a key element of universal health coverage and a fundamental pillar when it comes to social inclusion and quality of life. We emphasise the importance of integrating it in primary care and all areas of the health system, as well as the preparation to respond to emergencies. With regard to the health of indigenous peoples, we'd reaffirm our compromise to a participative and inclusive approach. Our country is home to many indigenous peoples, and we have promoted models of intercultural focus and strengthening primary care in those territories. However, there are still problems with timely access, infrastructure and specialised services. It's important to hear the voices and learn from the knowledge of indigenous peoples in order to formulate policies and also access disaggregated data to guide more effective actions. We also think with regard to mother and child nutrition, it's important to access towards global goals. We've particularly focused in this area in primary healthcare, promoting breastfeeding, food supplements with micronutrients, and ensuring that there is oversight of nutrition policies. However, there are still inequalities. We think it's important to continue to focus on integrated and intersectoral approaches which address all forms of malnutrition in the early stages of life. We reaffirm our commitment to move towards a more inclusive, equitable and person-centred system and call for strengthening international cooperation to ensure that there are sustainable resources and good practices are shared. Thank you.
Gambia followed by Slovakia, sorry.
Thank you, Chair. On agenda item 15.4, the Gambia commends the WHO Secretariat for the report on the implementation of strategies to improve maternal, infant, and young child nutrition. We welcome the progress achieved globally, particularly the adoption of legislation aligned with the International Code of Marketing of Breast Milk Substitutes by 34 member states. The Gambia has an exclusive breastfeeding rate of 54%, surpassing the global target of 50%. We are tackling maternal, infant, and young child nutrition through a whole-of-government, multi-sectoral approach and strong collaboration across the health, agriculture, education, and social protection sectors. Key interventions include strengthening maternal nutrition services through antenatal and postnatal counseling, iron and folic acid supplementation, and the promotion of adequate maternal diets. We have developed national food-based dietary guidelines to promote healthy diets across the life course and introduced community-level cooking demonstrations, to encourage the use of nutritious, locally available foods. Nutrition education and counseling are increasingly integrated into primary healthcare services and schools, supported by continuous capacity building of frontline health workers. The Gambia has strengthened nutrition surveillance, which has improved early detection and referral of acute malnutrition. Currently, the Gambia is reviewing its national protocol on the integrated management of acute malnutrition, revising the breastfeeding promotion regulation of 2006, and strengthening its enforcement to better protect, promote, and support optimal infant and young child feeding practices. Challenges include limited investment in nutrition programs, gaps in code enforcement, weak integration of nutrition into emergency responses, suboptimal complementary feeding, and the emerging burden of overweight and obesity. We therefore support extending this strategic plan to 2030 to accelerate progress towards global nutrition targets. Thank you.
Slovakia, followed by Kenya.
Dear Mr. Chair, in the context of demographic developments, including population aging and the rising prevalence of chronic conditions, the Slovak Republic considers rehabilitative care to be an increasingly important component of a modern and resilient healthcare system. Rehabilitation services form an integral part of the framework of universal health coverage and contribute significantly to ensuring continuity, accessibility, quality and long-term sustainability of healthcare provision. In response to the growing demand for post-acute and long-term care services, the Slovak Republic is undertaking a range of measures aimed at establishing appropriate and sustainability financing mechanism, while further strengthening the collection, reporting and evaluation of relevant medical and economic data within the post-acute care sector. Particular attention is being devoted to the role of rehabilitative care and its effective integration into broader healthcare pathways. Within this process, the Slovak Republic is focusing on the gradual development of initiative-based reimbursement models designed to support the provision of high-quality, patient-centered post-acute and rehabilitative care. In pursuing this objective, the Slovak Republic follows international developments and draws inspiration from examples of good practice implemented in several partner countries, including Switzerland and Australia, where comprehensive classification system and advanced financing mechanism for rehabilitative care have been introduced. The preparation of implementation of these reforms are being carried out in close dialogue with medical experts, healthcare providers, health insurance institutions, patient organizations, and other relevant stakeholders. The Slovak Republic remains committed to an inclusive, transparent, and evidence-based approach aimed at further strengthening the resilience, efficiency, and quality of its healthcare system. Thank you, Chair.
Kenya, followed by Germany.
Thank you, Chair. Aligns itself with the statement delivered by Angola on behalf of the 47 member states of the WHO Afro region. Kenya reaffirms its commitment to strengthening rehabilitation and assertive technology within health systems in line with the solution WHO 76.6 and the WHO Rehabilitation 2030 initiative. Kenya is integrating rehabilitation into primary health care, strengthening workforce capacity, improving rehabilitation reporting systems, and expanding access to assertive technology. We support WHO efforts to develop global rehabilitation indicators and effective coverage measures and call for sustained collaboration, financing, and technical support to ensure equitable access to quality rehabilitation services for all. On Agenda Item 15.3, Kenya welcomes the DG's report and reaffirming its commitment to accelerating progress towards the 2030 Global Nutrition Targets through strengthened policies, integrated service delivery, and multi-sectoral action. Kenya has made notable progress in reducing stunting and wasting and improving breastfeeding practices. We have updated Kenya's national wasting management guidelines in line with WHO recommendations, scaled up baby-friendly initiatives, and community-based nutrition services through community health promoters and advanced food environment reforms, including the Kenya Nutrient Profile Model. In conclusion, Kenya calls for renewal, global solidarity, and sustained investment to strengthen rehabilitation and nutrition essential pillars of universal health coverage and resilient health systems. We urge member states and partners to support sustainable financing, climate-resilient and people-centered approaches, strengthen regulation, digital monitoring systems, and equitable access to quality rehabilitation, assistive technology, and nutrition services, particularly for vulnerable populations. Together, we must accelerate implementation and accountability to ensure that no woman, child, or person living with disability is left behind. I thank you.
Germany followed by Thailand.
Chair, the first 1,000 days of life are crucial for the physical and cognitive development of infants and young children. And breastfeeding helps to provide optimal nutrition for infants starting from birth. For this reason, Germany is implementing a cross-sectoral national strategy which is aimed at improving the conditions for breastfeeding. In this context, we are eager to learn about the outcomes of WHO's work on suitable instruments to identify digital marketing activities for breast milk substitutes. Promoting healthy nutrition throughout childhood is another key aspect for Germany. This commitment is reflected in the implementation of the EU school scheme, which facilitates the distribution of fresh fruits, vegetables, and milk to millions of children in German schools and preschools. Germany also reiterates the importance of a primary healthcare approach, which ensures integrated access to essential services, including maternal health and SRHR services, which should be delivered by a qualified workforce. Investing in the health workforce, especially midwives, is a cost-effective way of expanding access to high-impact interventions such as prenatal care and micronutrient supplementation, breastfeeding counseling and support, and postpartum family planning. In conclusion, through these efforts and our multilateral partnerships, including with UNFPA, Germany continues to scale up the quality of integrated services for SRHR and nutrition. Thank you.
Thailand, you have the floor, followed by Bulgaria.
Thank you, Chairs. Thailand appreciates the WHO effort in supporting member states to promote health. Thailand views rehabilitation as essential, non-negotiable USC pillars, advocating for indicators that are evidence-based and adaptable to a specific national context. Methodologies for measuring coverage must be validated against local realities before being adopted as global standards. In terms of indigenous people health, it's crucial for achieving health equity. We uphold the principles of free, prior, and informed consent, and support deferring the draft plan to the 8th World Health Assembly to facilitate deeper, culturally appropriate dialogues. Chairs, as the global nutrition targets remain off track, multi-sectoral actions are required to leverage the desirable outcomes. In response, Thailand launched the triple power models, policy, partnerships, and community resources. Since 2025, results among early childhood in Palos province show reduction in wasting by 60%, stunning by 40%, and obesity by 20%. We request the WHO to integrate nutritional-related tools within operational framework for primary health care that empower communities to drive their own nutritional outcomes. Finally, regarding key challenges on cross-border online marketing of breast milk substitutes, Thailand saw violations nearly triple last year compared to 2024. We urge the WHO to develop tools to monitor and restrict cross-border online marketing in a timely and effective manner. Thank you, Chairs.
Bulgaria, followed by Denmark.
Chair, Bulgaria takes note of the Director General's report and reaffirms its view that the nutrition of pregnant and breastfeeding women, as well as infants and young children, must remain a priority within national health and nutrition policies, given its fundamental importance for healthy growth, development, and lifelong well-being. Bulgaria supports the need for regular reporting on progress of the comprehensive implementation plan on maternal, infant, and young child nutrition, as well as for strengthening efforts to achieve the global and operational goals by 2030. The Republic of Bulgaria also supports the reinforcing national measures to implement the International Code of Marketing for Breast Milk Substitutes, including the development and implementation of effective regulatory mechanisms to restrict digital marketing. Bulgaria supports the role of WHO Secretariat in identifying priority areas for action and in providing recommendations, technical support, and reliable data to assist member states. Recognizing the importance of nutrition for the health of mothers and children, and for achieving the Sustainable Development Goals by 2030, the Republic of Bulgaria supports the report's finding and the continuation of work on its practical implementation at both national and international levels. I thank you.
Denmark, followed by New Zealand.
Dear Chair, distinguished delegates, I'm a Danish youth delegate and I'm here to represent the voices of the youth. We all know how dire implication poor nutrition has on our bodies, especially in the developing and growing stages of life. But many young bodies are being deprived of the value and amount of nutrition they need to grow a healthy body and mind. I hope that I will one day live in a world where access to nutrition reaches even the most remote places, where no pregnant mother must face the decision of feeding herself or her other children, where healthy food is the cheapest and most accessible, where all children get the nutrition they need to grow a healthy body and mind. Let us make this vision more than a dream by taking responsibility here today and cooperate across borders with global health policies to help future generations. And by making intersectional, holistic, and scientifically grounded solutions that will increase food security, economic stability, and healthcare services. Let us do this so I can one day, when I'm older, tell the young people that we did this for them. Because nutrition is about more than food. It's about getting the chances to live our lives to the fullest. Thank you.
For the information of the committee, we may have to suspend to move to agenda item 20.2 in the next 30 minutes. But for now, we'll continue with agenda item 15. It is now the turn of New Zealand, followed by Zambia.
Tēnā tātou katoa. Thank you, Chair. New Zealand welcomes the development of the draft Global Plan of Action for the Health of Indigenous Peoples, recognising the importance of improving Indigenous health globally. We support the 5 priorities identified in the draft plan and underscore the importance of deep and inclusive consultations to ensure the plan reflects the diverse realities and lived experiences of Indigenous peoples. Central to this is genuine partnership with Indigenous peoples, including Indigenous leadership in the design and delivery of health services. While there have been improvements in recent years, Māori, the Indigenous people of New Zealand, continue to experience poorer health outcomes than non-Māori, including higher rates of morbidity and mortality, poorer mental health outcomes, and shorter life expectancy. Differences in life expectancy are largely driven by avoidable causes of death, including barriers to timely access to high-quality health services, addressing modifiable risk factors such as alcohol and tobacco use, poor nutrition, physical inactivity, and adverse social and environmental risks will also be important to reducing premature mortality. New Zealand considers that meaningful, culturally appropriate consultation is essential to upholding the free, prior and informed consent of Indigenous peoples. We support the planned regional and country-level consultations, including dedicated engagement with Indigenous peoples. We support the decision to defer consideration to the 80th World Health Assembly. We also call for the allocation of adequate and sustained resourcing to support comprehensive engagement and meaningful co-design with Indigenous peoples, as well as effective implementation. Ngā mihi nui. Thank you, Chair.
Zambia, followed by Tekie.
Thank you, Chairperson. Zambia welcomes the WHO Regional Strategy to Strengthen Rehabilitation Services from 2025 to 2035 and aligns itself fully with its vision of leaving no one behind in our region. Rehabilitation is a priority within our National Health Strategic Plan from 2022 to 2026 and is operationalized through the National Rehabilitation Strategic Plan for the same period. Zambia has also developed a national priority list of assistive products that are affordable, cost-effective, and meet minimum quality and safety standards. Zambia leveraging regional and international collaboration to increase access to assistive technologies. In 2027, Zambia intends to align its national assistive technology plan with the regional strategy through 2035. Significant unmet needs remain. Our rehabilitation workforce is too small to cover the population in need. Assistive products are expensive for many Zambians, and most of the products are imported. Zambia therefore requires strengthening 3 priority areas: sustainable financing, including domestic resource mobilization, scaling up of rehabilitation workforce, and technical capacity and resources to produce assistive products locally. Zambia therefore calls for partnerships with regional and international partners to stimulate local or regional manufacturing of assistive products. Zambia calls on the World Health Organization to play a catalytic role in this endeavor. I thank you.
Turkey, followed by Indonesia.
Thank you, Chair. Turkey welcomes the report on maternal, infant, and young child nutrition and reiterates the importance of nutrition as a foundation for lifelong health and sustainable development. We support the integration of the nutrition objectives into PHC system and national health policies. We particularly emphasize on maternal and child services. Protecting, promoting, and supporting breastfeeding remains essential alongside efforts to address the growing challenges posed by unregulated digital marketing and breast milk substitutes. Turkey underlines the need for strengthened multi-sectoral cooperation, equitable access to nutrition food, and enhanced support for vulnerable population, particularly in fragile settings. We also emphasize the importance of early prevention of the malnutrition, community-based approaches, and stronger country capacities to integrate nutrition across food and health systems. In this regard, Turkey has implemented important national programs through its family health centers, including routine growth monitoring for children, nutrition, counseling for pregnant women and mothers, and the Baby-Friendly Hospital initiative, which has significantly contributed to the promotion of the breastfeeding practices across the country. In addition, national school nutrition and obesity prevention programs have been carried out to encourage healthy eating habits and raise awareness among the children and families. Turkey remains committed to supporting evidence-based and inclusive policies to improve maternal and child nutrition outcomes for all. I thank you.
Indonesia, followed by Finland.
Chair, Indonesia upholds the foundational principle that efforts to increase access to health services must be universal and relevant for all. Progress toward universal health coverage and the SDGs depends on our ability to ensure that even the most vulnerable receive equal care. On rehabilitation, Law Number 17 of 2023 and Government Regulation Number 28 of 2024 provide integrated and continuous services across primary health care, referral systems, and community-based care. As a disaster-prone country, rehabilitation is also being integrated into emergency preparedness and recovery efforts. On maternal, infant, and young child nutrition, primary health care and life course approaches are vital, with a stronger focus on prevention, breastfeeding promotion, community-based nutrition interventions, and early detection of risk. We reaffirm the critical role of health workers and the community in bringing services closer to families. On the health of indigenous peoples, while maintaining that the concept of indigenous people is not applicable in Indonesia, we underscore that in drafting the GPOA, the diversity of each country and its historical and cultural context must be taken into account. Therefore, a more inclusive approach, including by reflecting other groups that may require greater attention, such as local communities, could help ensure equal access to health services. Indonesia will actively engage in the WPRO regional consultation scheduled in June and trust that our inputs will be duly reflected in the process. For these reasons, Indonesia supports deferring the finalization of this document to WHA 80 in 2027 to ensure that all perspectives are given full, balanced, and careful consideration. I thank you, Chair.
Finland, followed by Singapore.
Thank you, Chair. Finland highly values the consideration given to the health of indigenous people and the engagement of their representatives in this process. We support deferring the global plan of action for the health of indigenous peoples. This provides time for consultation, building upon the valuable regional dialogues. Inclusive processes are fundamental. Nationally, our first Sami Truth and Reconciliation Commission delivered its findings in 2025. The Commission highlighted the shortages of mental health and social services in Sami languages and intergenerational trauma rooted in the state assimilation policies such as residential school experiences. In response, Finland is committed to ensuring all Sami people can access social health services in their own language and to strengthening awareness in Sami languages, culture and history. We look forward to continued collaboration with WHO and Member States in order to adopt the global plan of action next year. Thank you.
Singapore, followed by Chad.
Okay. Yeah. Chair, Singapore thanks the Secretariat for the report on strengthening rehabilitation in health systems and maternal, infant, and young child nutrition. With aging populations, demand for rehabilitation grows. Access is insufficient if care is fragmented. Singapore advances a system-wide approach to our National One Rehabilitation Framework, aligning acute, community, and primary care with common outcomes and data sharing for care continuity. We commend the WHO's progress in implementing the plan on maternal, infant, and young child nutrition. To address these challenges, interventions should begin from preconception and continue through childhood. To this end, we have updated guidelines for gestational diabetes and published our first guidelines for early feeding practices, supporting healthcare providers and caregivers in targeting upstream risk factors. Supportive home and school environments are also critical in shaping children's dietary habits. Singapore promotes healthier eating at home through health education for children, practical resources for families, and supporting schools to provide healthy meals. Further details on our efforts in both rehabilitation and maternal and child nutrition are in our written statement. Singapore stands ready to share our experiences and work with WHO and member states to advance efforts in these areas. Thank you.
Chad, followed by Chile.
Merci, Monsieur le Président.
Thank you, Chair. Chad associates itself with the statement delivered by Angola, speaking on behalf of the 47 member states of the African region in WHO. We thank the Secretariat for the high quality of the report submitted to us, the report on maternal, infant and young child nutrition. We remain deeply concerned by the persistence of all forms of malnutrition in fragile contexts and also in the context of prolonged crisis. All of this is further worsened by the effects of climate change, recurrent flooding and episodes of drought. These things further fragilize the lives of the most vulnerable people in our world. In that global and regional context, Chad places nutrition at the heart of its development policies. Massive influx of refugees and displaced persons from neighbouring countries, especially Sudan, are also putting considerable strain on our national capacity to provide appropriate health and nutritional responses. For that reason, we share the concern expressed in our regional statement as to the growing difficulty of gaining access to essential nutrients and also the importance of prevention of problems. Given this situation, we reassert our commitment to strengthening the integration of nutrition within PHC programs, promoting breastfeeding, scaling up community interventions and building resistance within our food and health systems. We call for international solidarity to help thousands of vulnerable people in our country facing humanitarian and climate and other disasters and catastrophes. We need to act in accordance with the SDG goals that have been set for us. Thank you.
Chile followed by Fiji.
Muchas gracias, señor presidente.
Thank you. We welcome the reports and recognize them as a shared roadmap towards more equitable and resilient healthcare systems. We're making progress on rehabilitation in our 2021-2030 national plan, which recognizes this area as a central pillar, not a peripheral one, for autonomy, social participation, and quality of life, particularly in light of population aging and the increase in chronic diseases. Rehabilitation is also an equity policy. Chile, in the area of social connection, has co-sponsored with Spain and other states the first resolution of this assembly on that topic, adopted in May 25. We commend the WHO for beginning the process of developing specific guidance, and we urge that this process be accelerated and ensure that said guidance reaches national health systems with clearly verifiable indicators. In nutrition, a regulatory experience, such as warning labels, restrictions on ads aimed at minors, and healthy schools, has shown itself to be effective. Chile will continue sharing this agenda actively with other states. And finally, we place value on the emphasis of the health economy. There are growing budget constraints, and in that context, it's essential to remember that health is an investment, not a cost, and that we need to protect and secure progress in financial coverage and guarantees. Chile reaffirms its commitment to public health, which creates conditions for living with well-being, autonomy, and dignity. Thank you very much.
Fiji has the floor, followed by Lesotho.
Chair, on item 15.3, Fiji is pleased to make this statement on behalf of the indigenous people of the Pacific region. Health is inseparable from our cultures, languages, spirituality, ancestral lands, and ocean. It is woven through our identity, our collective well-being, our deep connections with the environment across our blue Pacific continent. Yet indigenous communities continue to face profound health inequalities, and the Pacific carries one of the world's highest burden of NCD, with more than 75% of death in our region. Climate change, geographic isolation, workforce shortages, and unequal access to healthcare continue to disproportionately affect our people, particularly women, children, and remote communities. Despite these challenges, indigenous communities remain resilient. Traditional leaders, women groups, youth networks, and community health workers continue to lead prevention, nutrition, mental well-being, and disaster response effort across the Pacific. They are the backbone of resilience in our region. The COVID-19 pandemic reaffirmed the value of indigenous traditional knowledge and healing practices, integrated alongside modern public health measures to strengthen community care and social cohesion. Indigenous knowledge systems are not relics of the past. They are living systems of science, prevention, healing, and resilience. Chair, the future of equitable healthcare cannot be achieved without inclusion, respect of indigenous sovereignty, and recognition of indigenous knowledge system. We reaffirm the right of indigenous people to maintain and protect and strengthen their traditional medicines and health practices, consistent with Article 24 for UN Declaration on the Rights of Indigenous People. We call for stronger investment in scientific research, documentation, and publication of the indigenous traditional knowledge through ethical practice, partnerships that uphold indigenous data sovereignty and community ownership of knowledge. The health of indigenous people cannot be achieved without indigenous people themselves. Lasting progress will only come when indigenous leadership, dignity, and knowledge are fully respected and empowered. I thank you, Chair, for giving me the floor.
Lesotho, followed by Colombia.
Chair, Director General, and distinguished delegates, Lesotho recognizes maternal malnutrition and infant and young child feeding as fundamental to child survival, human capital development, and universal health coverage. However, malnutrition in all its forms remains a major public health challenge. According to the 2023-2024 Lesotho Demographic and Health Survey, exclusive breastfeeding declined from 66% in 2014 to 61%, underscoring the need to strengthen breastfeeding protection and support. Anemia remains alarmingly high, affecting 70% of children, 51% of pregnant women, and 54% of non-pregnant women, with serious implications for maternal and child health. Childhood overweight has also remained unchanged at 7% since 2009, reflecting the growing double burden of malnutrition. Diet quality remains a key concern. Only 18% of women meet minimum dietary diversity, while complementary feeding practices among children remain inadequate. In response, Lesotho is scaling up evidence-based nutrition interventions across the life course, including micronutrient powders for children, strengthened infant and young child feeding counseling, and transitioning from iron folic acid to multiple micronutrient supplementation for pregnant women. Lesotho is also revitalizing the Mother-Baby Friendly Facility initiative and strengthening implementation of the International Code for Marketing of Breast Milk Substitutes, including addressing inappropriate digital marketing practices. We call for sustained political commitment, sustained financing, and global solidarity to accelerate progress and ensure every woman and child has the best possible start in life. I thank you.